Se bomo.
Dober dan. Dober dan.
Dober dan.
Pozdravljeni.
Kaj mi zdaj dela, da ne pridem noter? This will stop other screen sharing. Do you want to continue?
Slišimo
zdaj.
te.
Rečem, ja, ne?
Slišimo te in vidimo.
Me vidite, me slišite? Dobro, se bomo
Boje.
Ja, se bomo začeli. Tako, v takem lepem številu je situacija, bom rekla, zelo prijetna. Samo malo, da še jaz nekaj uredim. Aha, takole bomo naredili. Skratka, vsi lepo pozdravljeni. Me slišite vsi?
Slišimo.
Slišimo, lepo pozdravljeni. Za nas je kar nekaj. Počakali bomo, da bo čas korekten in potem bomo začeli. Mislim, da še minuta.
Gospa profesorica,
Ja, rečite, Matija.
imam eno vprašanje in sicer, ali dobimo kakšno prijavno kodo ali kako je s tem?
Saj vi ste že noter, Matija.
Aha, ok. Torej
Ja,
ni
ja.
treba nobene kode, ker ni.
Ne, nič več zdaj, nič več.
Ok,
Tako,
hvala.
Dober dan.
še kdo kaj želi? Če ne, bomo rekli najprej nekaj v slovenščini, potem pa tudi v uradnem jeziku naše konference, samo da bo čas korekten. Lepo vas je videti v takem velikem številu. Tako. So, many kind regards and a warm welcome to all of you on our section of social gerontology. Many of you ask me, be in email, be in personal, why the working language is in English. I must say it was not my decision, as you know that I am very proud of my mother tongue, it means in Slovenian. But however, I presume that the organizer have the decision that also we will be listening and seeing to the people all over abroad, it means in Europe and also in other cases. So about the time, each of us, we are the presenters, will please be in time. Not more than 10 to 12 minutes, that we will have some time afterwards for some decision. Today is a great day for the world science, because if he would be alive, it means Albert Einstein, he would celebrate today his birthday. And the other thing, also a Slovenian biological wise man, Jože Jesenko, who made so many patents in the field in the former century. So, on the list, am I the first who will present the situation? My paper, I'm sorry, yes. I will speak a little bit about competencies, skills, and everything about the problem of social gerontologist. As we say that social gerontologist in Europe, as well also in Slovenia, is not a new profession anymore, but it requires a multidisciplinary skill set focusing on the social, medical, nursing, psychological, and also policy aspects of aging to enhance the quality of life for older adults. This is our main goal. Key competencies include very interviewed and specialized communication, ethical decision working, care coordination, digital literacy for social well-being, and also promoting of social participation. So we have many competencies. I will just point out some of them, which are structures around several core areas. It means the first in interpersonal and communication skills, which are very important because they involve building relationships, active listening, and communicating very effectively with the older adults, and also taking in account their individual needs and their dignity. Secondly, care coordination and management. Social gerontologists as professionals must be able to organize, to manage, and to coordinate not only care, but sometimes the whole life of the adults whom are he caring for. Third, social and psychological focus. These competencies include promoting social participation, also addressing inequalities, be in gender and also be in age. Fourth, ethical and legal knowledge. It is very important that handling ethical issues, preventing abuse, and navigating regulation in social care for older adults, which are very critical. In updating the study content for the first degree of social gerontology on our university, we are also introducing new approaches to working with human robot and the role of entertainment and active aging regarding next. It means policy and community engagement. Then interprofessional collaboration. We know that we have to work with other professionals, be in the field of medicine, nursing, law, and so on. These competencies are often aligned with the framework roles, such as those developed in the European Core Competencies Framework for Health and for Social Professional working with older adults. In updating the study content, we are also introducing new approaches to work with human robots and the role of entertainment in active aging recording, social, commitment, assistive, and companion robots. Then use in medical treatment, mental health therapy, general nursing, physiotherapy, it means gerophysiotherapy, and other care facilities also in private homes. And last but not least, ethical concerns. The question of control, of privacy, of dignity, of conscience, and the issue of simulated versus human compassion in caregiving, usage of rhetoric of urgency concerning aging population, driving the development of the robots. And therefore, I prepared for you a short video. How, for example, very important, the human robots nowadays for older adults, also in Slovenia, but also in Europe and worldwide, are very welcome. You see?
Yes, that
Ne
is.
slišimo.
So, however, you see that this little video showed us how very important the personal and emotional contact to the older adults is. So we knew nowadays so many human robots in promoting active and productive, less a little bit productive aging. But however, this active aging and the importance of these human robots, here on the picture, I put some of them, but there are many. You know that China, however, but also other industrial, high developed countries developed various type of human robots. However, only reminding you, it was the first book I read about it. It means Robot Ethics by John Havden, who asked Michelangelo by the artificial intelligence, what does it mean to be human? 2070, I, with a colleague of mine, I published a scientific book on the Faculty of Medicine, University of Maribor. And on the front part, I had the same picture. The difference is that these two hands, they were human. Nowadays, we see one of them is not. However, despite the acute staffing needs in Slovenia, social gerontologists are facing an unreasonable decision by the Ministry of Labour in January last year, when one official of this ministry announced, to our great surprise, that social gerontologists can only take the professional exam under Article 70 of the Social Welfare Act and not as yet before under the Article 69 of the Social Welfare Act. We strongly oppose this at the Department of Social Gerontology. And I give my word that our efforts, regardless of the government that will be formed after the upcoming elections in Slovenia, are aimed at eliminating this unreasonable decision, as it causes considerable problems in the employment of social gerontologists in Slovenia. That was from my side. So a little bit of everything, but however, we know that we on our field of social gerontology, we have so many new contents to be discussed, so many new ways, and I think I was in time in 10 or 11 minutes. Thank you for listening to me. Now I will call Emma Turnšek, who is PhD candidate in Central European Academy and Dick Ferenc Doctoral School of the University of Miskolc in Hungary. She prepared, together with her mentor, Professor Dr. Zuzana Kraljevic, Faculty of Law, University of Maribor, titled Integrating Elderly in the Digitally Advanced Healthcare System. Emma, are you present? Emma, are you present? I'm sorry, she's not. So I will call our PhD student, PhD candidate, Alexandra Lučičnik, who together with my dear colleague, Professor Dr. Majda Bastic, prepared nursing staff satisfaction in long-term care homes. Alexandra, the floor is yours, please.
Dr. Goriupova, nice to see you again. Thank you for the word. So I will start to share, if that's okay.
Yes.
So, you see the screen?
Not yet.
Not yet?
Not yet.
Now, what is wrong?
Yes,
See you? Yes, okay.
Yes.
Thank you. Thank you. Good morning, ladies and gentlemen. Thank you very much for the introduction, for the opportunity to present our work at the Alma Mater 2026 Scientific Conference. As it was said, my name is Alexandra Lučičnik. I'm PhD candidate in social gerontology, and together with Dr. Majda Bastic, we conducted this study. Today, I'll be talking about the job satisfaction among nursing staff working in long-term care homes in Slovenia. I will briefly outline the background and context, describe the methodology, present the key results, and conclude with practical implications for management and future research. No, move. Sorry. Okay. Long-term care homes are currently operating under sustained pressure across Europe. Staff shortages, increased care complexity, and rising expectation from families and institutions have become part of everyday practice. Employees in long-term care homes are exposed to both physical and psychological strain, which affect their well-being, job satisfaction, and intention to remain in the profession. Job satisfaction is therefore not only an individual issue, but a key organizational factor. Lower satisfaction is associated with burnout, higher turnover, and reduced quality of care, while higher satisfaction supports continuity, safety, and better outcomes for residents. These challenges are particularly relevant in Slovenia due to rapid population aging. In 2025, more than 1/5 of the population was aged 65 or older, and the aging index shows that older adults are significantly outnumbered children. This demographic shift increases the demand for long-term care services, both institutional and home-based. However, the workforce in long-term care is not growing at the same pace. Long-term care homes increasingly struggle to recruit and retain qualified staff, which makes it essential to understand which factors more strongly influence job satisfaction and retention among existing employees. Against this background, the main purpose of our study was to examine job satisfaction among nursing staff employed in long-term care homes in Slovenia. We were particularly interested in identifying which aspects of the work environment contribute most strongly to satisfaction and whether these factors differ between professional groups. Understanding this relationship can support evidence-based management decisions and help prioritize intervention in resource-limited settings. We focus on three main objectives. First, we have to aim to compare job satisfaction between nurses and caregivers, as these groups often differ in education, responsibilities, and pay. Second, we examined the relationship between perceived psychosocial support from colleagues and overall job satisfaction. And third, we tested whether job satisfaction could be statistically predicted by selected organizational factors, including workload fairness, mutual respect, salary and benefits, and staffing sufficiency. So, we conducted a quantitative cross-sectional non-experimental study. Data were collected in 2 long-term care homes in Maribor area, and the survey was opened between June and August 2025. Of the 52 employees who opened the survey, 35 completed it fully, and these responses formed the final sample. The sample included nurses, caregivers, and one respondent who identified as a guardian. Although the sample size is modest, it reflects the structure of staffing at the participating institutions. Job satisfaction was measured using a modified version of the nursing home administrator job satisfaction questionnaire and, of course, processed by the SPSS. We assessed 6 dimensions: support in the work environment, teamwork and communication, work organization and workload, education and development, pay and benefits, and user care and work impact. Respondents rated each statement on a 7-point Likert scale, and the overall satisfaction index was calculated as the average score across all items, allowing us to examine both general satisfaction and specific contributing factors. The overall job satisfaction score was moderately positive, with a mean value of 4.88. The distribution of responses was relatively homogeneous, indicating that most employees shared similar perceptions. When comparing nurses and caregivers, we found no statistically significant difference in satisfaction levels. Both parametric and non-parametric tests confirmed this result. This suggests that professional role alone does not explain differences in job satisfaction in long-term care homes, and that shared working conditions may be more influential. One of the strongest findings of our study relates to psychosocial support from colleagues. We found a very strong and statistically significant positive correlation between perceived support and overall job satisfaction. Employees who felt supported, respected, and part of a team reported substantially higher satisfaction. These highlights are important of interpersonal relationship and team climate in long-term care settings, where work is emotionally demanding and collaboration is essential. To identify key predictors of job satisfaction, we conducted multiple regression analysis. Among the examined factors, satisfaction with salary and benefits emerged as the only statistically significant predictor. It explained nearly 29% of the variance in overall satisfaction. Other factors, such as workload fairness, mutual respect, and staffing levels, did not remain significant once salary was included in the model, although some showed positive trends. This suggests that adequate and fair remuneration may be a necessary baseline condition for job satisfaction in this context. These findings underline the multidimensional nature of job satisfaction in long-term care. While psychosocial support is strongly associated with satisfaction, remuneration appears to play a decisive role when multiple factors are considered together. From a management perspective, this indicates that effort to improve teamwork and support should be accompanied by transparent and fair pay systems. Even in settings where staffing numbers cannot be rapidly increased, strengthening team support, mentoring, and communication may help mitigate dissatisfaction and reduce turnover risk. In conclusion, our study shows that more job satisfaction among nursing staff in Slovenian long-term care homes is moderately positive and similar across professional groups. Satisfaction with pay and benefits is the most important predictor of overall satisfaction, while psychosocial support plays a crucial complementary role. This study is limited by its small sample size and cross-sectional design, so future research should include larger, multi-site, and longitudinal studies. Nevertheless, the findings provide practical guidance for managers and policymakers seeking to improve staff retention and well-being in long-term care homes. Thank you very much for your attention.
Thank you very much, Alexandra, for your presentation. It was very interesting. As you know, who is guiding this lesson should not make some comments now, because this is the role of all of us at the end of that. I have now the information that Emma Turenschek was somehow lost in another section. So please, again, Emma, you prepared the presentation together with Professor Dr. Susanna Kraljic, as I said, about integrating elderly in the digitally advanced healthcare system. Emma, if you have not been here, you have 10 to 12 minutes. Yes, please, the floor is yours.
Thank you. I want to apologize also from my side. I'm really sorry to be late. I was in another channel, as you were informed, and I hope that this doesn't really influence my presentation today. I will put on my PowerPoint.
Yes, share it.
Can you see it?
No, not yet.
Not yet? Okay, here. Okay, now?
Yes, it is going on. Yes, thank you.
Perfect. Okay. So my name is Emma Turenschek. I'm a PhD student, assistant, researcher, not really in the field of elderly and the policies regarding their care, but in the field of data protection in healthcare. So today I will be connecting the two fields. I prepared this presentation together with my supervisor and mentor, Professor Susanna Kralic. So I hope that you enjoy hearing our findings. With the technological developments, life is becoming or should be becoming easier in various aspects of life, sectors, and especially in healthcare. Moving forward, and also by various additional steps, healthcare sector has gone to digital environments in a very great percentage. So particular services are now more approachable via Zvim app. Some services are, with the help of this technology, becoming fast-tracked. Many tasks should, with the technological development and with the assistance of advanced machinery, be less time consuming and now more efficient. And also communication with doctor's office is now becoming easier and can go through various channels. For example, when I have migraines and I have pills for it, when I ran out of them, I can just call the doctor or write an email and I get the prescription in Zvim app. And the only thing that I have to do physically now is to go to the pharmacy to get those pills. 10, 20 years ago, that maybe wasn't possible like today. So the positive effects are especially important in healthcare, where the smallest change can have enormous success and influence on the individual's life. I gave a very simple example, but in some cases, such developments could even save a life. While the technology may have enriched our lives with snowball of positive effects, it at the same time leaves certain people with somewhat negative consequences. The thing is that with the idea of digital development in healthcare, no one really thinks about the people who do not have idea of digital development in healthcare, the resources, the skills, the knowledge on handling these new digital or technological devices. These are in most cases elderly people or people with special needs. The group of people that uses and needs the healthcare services the most. Slovenian as well as other nations' healthcare systems are quite rapidly integrating their data and services into online environments. With each change in practice or by each change in the legislation, institutions forget to take measures for integrating elderly into these newly developed apps, online platforms, and more. Well, maybe they don't forget, but maybe they just don't give the resources into education on this matter. There are groups that offer technically this help and education. However, these groups are quite limited in the number of people offering help, in the locations or spots that they give this education, and also they remain poorly advertised, and in many cases, elderly are unaware of them. In education, it is really important to cover all the people, the elderly, the people with special needs, maybe even randomly adults that don't have much of technology in their daily lives. For example, some people are working physically, either in factories, maybe they are working on the field, and they are not having the opportunity to be in front of the computer or have phone on their ear all the time. So they need more education, more, let's say, lessons on this matter. And also, I want to share this statistical information that I've came across. It was proven that we have a low level of organizational health literacy in many healthcare institutions where information and services are not always adapted to these diverse needs of users, especially to different vulnerable groups. Another interesting fact is that in the Republic of Slovenia, nearly half of adult population has difficulties in understanding, evaluating, and using health information. So this consequently reduces participation in preventative programs, complicates the effective management of chronic diseases, and also increases the burden of the healthcare system. Insufficient health literacy is also reflected in poorer awareness of rights and opportunities within the healthcare system, unequal access to information among different population groups, and insufficient use of digital tools in the field of e-health. So, as we mentioned, these tools are now helping to ease our daily lives, but to some individuals, they don't have such effect. Yet, these people are not given the same opportunities to be familiarized and taught about the procedures, steps that should be taken. For example, when you register yourself at the machine, well, that does not leave them, especially elderly, without the needed medical treatment, but for sure it does leave them with inconvenience, with a feeling of being left out, even maybe. So integrating elderly in the digitally advanced healthcare systems should not be a recognized fallout in our healthcare systems, but a common measure connected to every technological development that directly impacts on their usage of healthcare. There are, of course, also advantages and direct benefits that elderly get from this digitalization of healthcare. And I also want to emphasize this positive side of it. In Slovenia, vulnerable people are actually given technical option. This option is actually given to everyone, but it's used mostly by elderly. This is the technical option of authorization of a designated person, meaning, for example, a grandmother can authorize her grandson or her daughter to perform certain tasks on her behalf through this patient portal Zvim app. But another positive thing about Zvim is that it somehow, yes, burdens elderly, but it actually benefits them with the option of having everything in one space. Especially for elderly, it is known that they can easily forget about something or they can misplace a document. Even I can do that. Even that happens to me as well. But having this application where you have all the documentation needed, it helps with data flowing. It helps with having medical documentation at one place so that there isn't a problem when a doctor wants to make a diagnosis. He or she will have all the needed information at one place in this app, in this register that is quite huge. So there will be no misplacement or losing of a document, not by the patient and also not by the medical or healthcare staff. With
yes,
that,
Emma, just have in
yes.
mind your time is running out. Please make a
Okay.
conclusion.
Okay. I want to also draw your attention to resolution on the National Healthcare Plan. This is a plan that has 10-year gap, and it emphasizes some positive measures that shall be taken in order to improve digital literacy among elderly and in general. So I think this is a very important document that brings a lot of positive ideas, and I really hope that it will be implemented as it is written. I guess I don't have a time for a conclusion, but still a sentence or two to end my presentation. I think that healthcare is really rapidly developing. And with that, as I mentioned, we often forget about the vulnerable groups. With this resolution that I mentioned, you can see there are some of the ideas, some of the developments that they want to focus on. And I really hope that it comes to realization, because I think it will be a great improvement in the field of development, in the field of educational models, and integrating elderly into the healthcare system that is more digitalized now. Thank you for your attention, and I hope it was interesting to you what I had to say. Connecting
However,
these
it
two
was,
things.
Emma, thank you, very interesting. Only one remark.
Yes.
For years, we are not speaking about elderly anymore. In the field
Okay.
of literature of the term, we speak about older adults. And this was
Okay.
also by the Chamber of Nursing in Slovenia adopted 2 years ago. So we have to be in time. It's not a big mistake, only for your information.
Thank you.
Thank you. Can you make your yes? Now I'm calling Tilen Medved, who is also PH candidate, and who prepared together with my dear colleagues, Professor Kern and Professor Balantic, Faculty of Organizational Science in University of Maribor, the ergonomic strategies for reducing labor shortages in an aging workforce. Tilen, the floor is yours, please.
Hello, everyone. I hope you can see and hear me well.
Yes.
Okay, therefore, I shall start with my presentation. Like it was mentioned, I'm going to talk about ergonomic strategies for reducing labor shortages in an aging workforce. So yeah, my name is Tilen. I'm an assistant from Faculty of Organizational Sciences. I've been with the field of ergonomics for quite some time now. Firstly on my bachelor's thesis, and then also on my master, and now even when I'm doing my PhD, I'm also researching similar fields. So this presentation that you will have the possibility of listening to in the next couple of minutes has to do something with what we did as a research for my master's thesis. So, okay, and if you're in this session, we are talking about elderly, older employees and older people. Okay. So overall, why we thought this
Adults, still an older adults, older employees,
adults. Okay,
but older adults. Yes.
In my presentation, you will see the term older employees. So I think I got this correct. So why this matters? Workforces are aging while organizations face labor shortages. As you know, Slovenia has an aging population. That's because we are a well-developed country, and the baby boom generation is slowly coming into the pensions. They're getting older, so therefore poor ergonomic conditions tend to impact older workers more. So we also found our literature that low-cost changes such as lighting, micro breaks, and so on support work participation, not just for the older workers, but also for every worker. So the study question was, can we significantly reduce presentism, which is on one hand when a worker feels pain or is unwell and goes to the doctor to get diagnosed and has his sick leaves or basically days off. oh, sorry, this is absenteeism. And presenteeism is when the employee does feel, let's say, pain in his knees or in his lower back, but decides to keep working, which also negatively impacts his health even further, but also impacts his productivity, efficiency, and so on. So we're trying to find if appropriate ergonomic workplace design is good for lowering the labor shortage that we have. And we triangulated this problem into three main categories. Like I said, aging population, workforce shortage that we are going to have in Slovenia, and the increasing amount of work-related musculoskeletal disorders. And as a solution, we propose ergonomics. And here are also the main three hypotheses that we tested. More on that later on. So we did a cross-sectional online survey. We had 31 questions. We measured many different things. We got 80 valid responses. The split between genders was like close to 50-50. And yeah, we had a lot of older workers as well. 23% were over 55 of age. And we did some Spearman correlation coefficients, descriptive statistics, and so on. Okay, so perceived increase in negative effects of physical workplace, do they increase with age? We found out that they do. And how do they look like? Well, if a worker has a forced or static posture, that impacts their health even more negatively if they are getting older and older. Also, repetitive movements, poor lighting in the workplace, even high noise level. Why would we say that? Because, as you know, when we are getting older, many of our psychological parameters also get worse. This is from the book of my mentor, of my PhD mentor. So, yeah, this is already quite well proven. With age, we are getting better cognitively, most definitely, but psychologically, we are getting less efficient. So, and we also took a look at the prevalence of key organizational and psychological factors, repetitive work, we've all been there, monotonous work, even working dynamically in a fast pace. This also impacts quite not just physical work, but also office work as well. Low support from co-workers, supervisors was also one of the factors that was taken into account, and workers gave their answers that they do not receive maybe the support that they would want. And also, yeah, physically demanding work and so on. So, and then we also asked on the questionnaire, the workers, how many times they were absent from work in the past year. And this is the results we got. Some were never, which is quite impressive. 1 to 2, we got 44%. And some 14% were absent even more than 6 times. And lastly, we had 31 questions. I had to cherry pick the most, I think, interesting ones for you. We also asked how do these asked individuals perceive how the measures would address labor shortages that we will soon have in Slovenia, if we don't even have them yet. So yeah, investment in workplace ergonomics was in the leading category. Even younger adults, many students are listening here. I think getting into the job market or labor market earlier, I think is also a great advantage. Robotization was also mentioned already, automatization of work, even migration is also a part, but only 15% saw that as a solution to our problems. And then we also try to ask them around some good practices of proactive ergonomics. Why proactive? Because we're trying to include ergonomics in the early stages of the organizational development, not when things already go wrong and we try to go corrective and change things that are already getting worse. So some of them were, let's say, does a worker have a possibility to visit an occupational physiotherapist? And 2.4, this is like a mean from Likert scale from 1 to 5, said that at the current state they had 2.4. possibilities of getting to the physiotherapist, but the desired state that they would want was 3.7. So that saw the most difference. Also, let's say exercise at the workplace, that they have a possibility to exercise, individual health programs, ergonomic floor mats. And here below you also see, let's say, job and task rotation. And this is my main field of study currently. So how can we rotate tasks within an organizations to keep workers more healthy and less overloaded with work. So, okay, so some of the key takeaways that I'm going to talk about now are that, yeah, employees expect poor ergonomics to affect older workers more. Of course, especially physical demands. The sectors that were questioned in this questionnaire were all over the place, but I think still, because we had an online survey, maybe there were many more from office work but than physical work, but overall, I think this point still stands. Ergonomics was seen as a top labor shortage response. This was selected by 70%. And yeah, many agree that ergonomic improvements help all employees, not only older workers. And this is important because we have to include ergonomics throughout the whole life cycle of a worker, not just for the elderly. Because if we do not include it for the worker's whole lifetime, the worker will see his health decrease when he gets older. So yeah, so what we can do, of course, like micro breaks, stretching, if we have like very monotonous work, or maybe if you have very physical work, let's say in a warehouse, we have to take some time off, break, to get our energy levels back from fatigue. So regarding hypothesis, the first one was confirmed. The second was how do you say, not confirmed. Why? Because we asked workers how many times they were absent, but not how long they were absent for. So yeah, here I have, let's say, some data from 2024 for Slovenia. Workers up to the age of 44, when they are absent, when they have sick leave, they're absent for around 7.5 days. Once from 45 to 64 of age, they're absent for 20 work days. And once we get older than 65, the worker absent days off are of 51.4 days. So yeah, this is maybe we should have asked how many days were you absent in a year, not how many times if did you have sick leave. And the last one was also confirmed. So the last sentence that I'm going to leave you with, because as I see my 10 minutes are up. As the population in Slovenia is aging, we must invest in ergonomics if we want every worker to age healthily. Like I mentioned earlier, this was my master's thesis, but now this conference I saw as a great opportunity to be an ambassador for ergonomics and maybe to get some of you to know the field, and that it's not just ergonomic tools and chairs and everything, but it's a lot more than what we talked about here in this short 10 minutes.
Yes.
Okay, so
Yeah, Dylan, very much. Thank you very much. Just an information, we also implemented the contents of ergonomic strategies in our new study program. And it, by the way, the professor, Dr. Jadra Kastričević, whose mentor was the same professor, it means Professor Dr. Balantic, she will do it in the field of nursing and in the field of social gerontology. So we now realize how how space we have and how important is our co-working. So, however, yeah, thank you, Dylan.
Yeah, if you have been, thanks for listening.
Yeah, it was interesting. However, so I'm calling Assistant Professor Dr. Janez Mayer from the University of Maribor. Is he present? Professor Dr. Mayer, also a colleague of us? If not, we will call him later on. But our colleague Renata Schabeder, who is PhD candidate on our Alma Mater University. She is present, and she prepared the titled presentation, Social Isolation and Loneliness Among Older Adults, a comparison of residential care and home settings. It's very interesting, and some of students made in the past also some researches about that. But however, there are new information, I'm sure. Please, your presentation should be.
Do you see it?
Yeah, not anymore.
Just a minute.
By the way, as Renata is preparing, yesterday was a long working day, 4 hours together. It was not an easy to be there, but it was worth. However, we will speak in different situation with our students about that. So please, Renata, you are prepared, are you?
Yes, can you see it?
We can see.
Okay.
Thank you.
Hello, everyone. I've prepared a literary review over social isolation and loneliness of older adults, a comparison between homes for elderly and the home environment. It is on the screen where I have. Okay, it's functioning now. While I have a little bit technical problems.
It is functioning, yes.
Yeah, okay. The highlights from this presentation, the challenges was the social isolation and loneliness of older people and the impact of physical and mental health. The objective was comparison between her home environments and home for the elderly. The findings was effective solutions to reducing loneliness. Methodology that was used was review of 13 scientific studies in period from 2020 and 2025. And the role, we found out that the role of the quality of social interactions, customized and holistic approaches, and promoting social inclusion. That was the take-home message. The introduction. Social isolation and loneliness is a global challenge. Social isolation.
Renata, I'm sorry.
Yeah.
Renata, I'm sorry to interrupt you, but we are still on the first slide.
Okay.
Yes. Can you go by hand? Yeah, it will be.
Okay.
Thank you.
Okay. Yeah, I have a little bit technical problems. That's why I asked of this going forward. This slide I have already now introduced. The introduction. Social isolation and loneliness is a global challenge. Social isolation is absence of sufficient social context, and loneliness is a subjective feeling of lack and of connection with others. Negative consequences for physical and mental health are cardiovascular diseases, depression, cognitive decline, premature mortality, and increased use of health services. The statistics says in 2024 was 10% of world population older than 65 years. about or over 800 million people is older than 65 years. In Europe, this rate is above 21%, and 20 to 30% of older adults experience loneliness, and the women experience more than men. The next tables I have only in Slovene. These are overviews of that all 13 studies of loneliness and social isolation of older adults. You can see it. I made it overview with authors. The purpose, what type of study was, the sample methods and key findings, applications, and this is, I would just not present it each one extra. The next slide have I also in Slovene that have not translate. The living environments and their impact. Home environment, the older adults that live in a home environment have greater autonomy, but a limited social context and higher level of loneliness. Women and individuals in rural areas are more exposed. Reduced this mobility and limitation of external context by the elderlies living in a home for elders. They have multiple structure interactions, but also lack of deep and meaningful context between the residents and the staff. And use of the technology and personal intervention is increasing with the technology era. The key findings from this literary review was the role of quality of social interaction. That quality of social interaction is more important than quantity. Then tailored interventions to reduce loneliness, such as group activities, yoga and mindfulness, walks, interactive games, and through a group workshop, individualized approaches, art therapies, musics, and tactile massage are positive of reducing loneliness, have positive impact. And then the role of technology, interactive online courses, online group therapies. Then we have also examined effects of the COVID pandemic on loneliness, because it was in this time from 2020 to 25 in these researchers. The increased loneliness was found especially by women and people with chronic diseases. Then the impact of sleep on social connection. The older adults, there was having sleep deprivation. The researchers had shown that they were more social isolated. A recommendation for improving social cohesion are intergenerational programs, increasing access to technology, holistic approach, nursing home support, personalized intervention, development for local community centers, and promoting on physical activities. Conclusion, we have three key messages for practice. The role of quality of social interactions, personal context, and digital technology. Customized and holistic approaches, promoting physical activity and improving sleep, and promoting social inclusion with integrational programs, local community centers, and outdoor social activities. Thank you for attention.
Yes, thank you for your presentation. Social isolation is a very important topic in the field of social gerontology. So I'm calling again Janus Meyer. Dr. Janus Meyer, is he present? I didn't see him, so he is following up. I have now two propositions. We have now enough time for a discussion and for a little pause. Yesterday, who were present there at the Alma Mater University, we have been sitting for 4 hours without a pause, and I'm sure it is not healthy and it is not productive. So I'm now open the floor for our discussion. Please, because I saw that the majority of us are Slovene, I make a suggestion. If you agree with it, that we should make discussion in Slovenian language. Nobody from other language part is present. Torej, če se strinjate, bi odprla razpravo v slovenščini, ker kolikor sem zdaj pogledala, nihče ni bil tujec in smo bili same Slovenke in Slovenci in bi zato tudi odprla razpravo v slovenščini. Se strinjate? Je kdo proti? Ja, moramo. Demokracija in svoboda sta zdaj zelo veliko opevana. Če še enkrat povzamem, o čem smo govorili, torej nekaj sem jaz v začetku povedala o samem socialnem gerontologu, o tem, da tudi v prenovljenih študijskih programih in na raziskovanju delamo tudi z humanoidnimi roboti, da je naša naloga ta, da za naše študente uredimo, tudi spremenimo, ne, in odpravimo to, bom rekla, nerazumljivo situacijo v strokovnem izpitu, takoj po volitvah, ne glede, kdo bo prišel tudi na oblast. Ema nam je nekaj povedala o povezovanju starejših in bom rekla, v tem digitalno usposobljenem zdravstvenem sistemu. Aleksandra je v tem, v čemer je najbolj doma, ne, to je področje tudi dolgotrajne oskrbe v domovih ali kakorkoli. Tilen nam je predstavil zelo zanimivo vsebino o ergonomiji, kako se ta pravzaprav pojavlja na eni strani starejšimi odraslimi zaposlenimi, koliko so odsotni in tako dalje. In pa gospa Šabeder nam je povedala nekaj o osamljenosti starejših. Odpiram razpravo, ne bomo tiho. Izvolite.
Ja, bo spet medicinska sestra začela.
Ja pa nekdo mora začeti.
Ergonomija, se učimo, zdaj je tudi postala del srednješolskega, tudi poklicnega izobraževanja, izjemno pomembna stvar, ker vse to, kar je gospod naštel, definitivno vpliva ne samo na dolžino trajanja delovne dobe zaposlenih, ne samo to, drugič, saj veste, starejši odrasli so populacija, ki v veliki večini primerov ne samo, da so, meni je žal, da se izgublja, ne, zdaj za to dolgotrajno oskrbo, tisti prvotni namen domov za dolgotrajno oskrbo. In sicer, da ker potrebuješ socialne stike, ker potrebuješ nekaj več, zdaj pa se v bistvu spreminjajo skoraj da v negovalne bolnišnice in tule delati brez podpore robotike. Zdaj, na tiste vaša slika mi je bila zelo všeč, doktor Gorjupova, ampak manjka pa Rover. To je en medvedek, en robot, ki je v bistvu za dvigovanje in za pomoč pri dvigovanju. Saj jaz ne rečem, da nimamo tega, ampak ergonomija je izjemno pomembna. Tudi v učenju, in tako kot sem rekla, se sedaj vključuje tudi v kurikul izobraževanja, recimo bodočih bolničarjev, negovalcev, ergonomska načela in kako ravnati. Tako da jaz mislim, tule ergonomija nikoli ni odveč, no, niti nikoli ni izobraževanje odveč o tem.
Aleksandra, zelo, zelo dobra pripomba. Bomo pa rekli nekaj, ne? Da ta predmet oziroma vsebine ergonomije na Univerzi v Mariboru, Fakultete za zdravstvene vede, že obstaja in že obstaja nekaj let. To moramo izpostaviti, ne? In na tem visokošolskem izobraževalnem področju je bila profesor dr. Jadranka Stričevič prva. Ja, tako. Ampak kakorkoli, za vse nas je to zelo pomembno. Kar pa se tiče to, kar ste povedali, tega drugega robota, ne, ki je že v marsikaterem domu oziroma tudi v bolnišnicah prisoten. Jaz sem v tistem slajdu potem samo, bom rekla, pokazala tega, kako čustveno je tudi to lahko v pomoč starejšim odraslim. Ne. Naslednji slajd pa, da jih imamo zelo veliko teh tipov. Ne. Ampak kakorkoli, to je zdaj moje prepričanje, vi boste imeli svoje. Jaz ocenjujem, da nam bodo ti humanoidni roboti v veliko pomoč, hkrati pa jaz ocenjujem, da je še ta neposredni face-to-face contact, by the call, ne, kot rečemo, še vedno zelo pomemben. Namreč robot ne čuti, ne izraža čustev, jih ne prepoznava, kakšni bodo stiki. Lahko da bo to v bodoče, ko bom jaz tam gor nekje nad oblaki, ali pa mogoče že prej. Ne? Ampak jaz še vedno stavim na to, da stisk roke, lep pogled, nekoga malo pobožamo, da je to. Lahko pa da bo to... Ja, izvolite.
Absolutno se strinjam z vami, dr. Gorjupova, zato pa je treba tudi 16-17 let stare dijake, ki bodo bolničari, negovalci nekoč naučiti ergonomskega dvigovanja, zato da bodo to lahko počeli z teh svojih 40-42 let, ker na prvem mestu je topla beseda in na prvem mestu je tisto, da mu podaš roko in da si ob njem takrat ne samo v fizičnem aspektu, takrat, ko nekaj potrebuje, ampak predvsem ob njem. Ljudje smo duhovna bitja, ne?
Točno tako.
Sestavljeni iz mesa in kosti.
Ja, najlepša hvala. Tilen, vi ste zelo lepo izpostavil ta situacijo, ne? Prezence in absence na delovnem mestu, ne? Zdaj tu se pojavlja eno vprašanje, ki bo zagotovo izven vašega konteksta, ne? Namreč večino evropskih držav oziroma članic Evropske unije, pa tudi sicer v drugih državah, ne, zdaj izpostavlja jasno potrebo zaradi podaljšanja življenjske dobe, da se bodo upokojenci lahko in marsikje še že, kot recimo na Finskem, ne, zaposlili tudi potem naprej. Kako se bo, zdaj pa moje vprašanje, ki je seveda spekulativno, kot bo verjetno tudi vaš odgovor, ali pač, ne? Kako pa zdaj z naraščajočo starostjo? Kako se bo pa ta situacija prezence in neprezence oziroma absentizma kazala? Kaj menite?
Ja, mogoče eno stvar, ki nisem vmes omenil, ker je bilo malo premalo časa, ampak ja, prezentizem pa absentizem, jaz bi rekel, izmed teh dveh je prezentizem še bolj ta glaven, kjer mi veliko enega denarja zgubimo, a ne?
Ja.
Če gledamo pač za starejše, tudi dejstvo je pač, da starejši imajo več enih problemov, ne? Zdaj bojo zaradi tega ostajali doma, a bojo še naprej hodili na šiht, to je drugo vprašanje, ampak jaz bolj mislim, da jih probamo izven obeh teh dveh pojmov, ne? Prezentizma pa absentizma ven izpeljati, se pravi, da sploh nimajo nobenih kakršnih koli zdravstvenih ali pa podobnih težav, ne? Ker prezentizem, kakor sem omenil, je pač pojem, ki se uporablja za tiste, kjer imajo določene bolečine ali pa tudi mogoče psihološke težave, pa še kar hodijo naprej na delovno mesto, ne? In takim zadevam se probamo izogibati. Zdaj, kako to narediti za starejše, mogoče je tudi ena izmed rešitev to postopno, počasno upokojevanje, ne? Naprimer, da ga damo delavcu delati za 6 ur, pa za 4, a ne, pa tako gremo postopoma. Zato tudi en del ergonomije je tale organizacijska ergonomija, ki tudi govori, kako mi recimo lahko delavce imamo individualne sisteme upokojevanja za njih, a ne, to je tudi en del lahko tega, ne. Tako da jaz mislim, da se hočemo izogibati temu, ja, čim več vlaganja v to, no. Vlaganja v človeka, pa v zdravje človeka, ne. Tudi industrija 5.0 govori o tem, ne samo trajnosti pa odpornosti, ampak človeka postavlja v spredje, ki je pa še vedno bolj pomembno tudi zdaj zaradi, naprimer, zadev, kot je umetna inteligenca, ki se to govori zdaj o tem. Tako da človek zdravje v spredju, tako pač na splošno je v ergonomiji, ne, da imajo tudi potem te starejši zaposleni, starejše osebe, ki pridejo domov po 8 urah dela, naprimer, da imajo še vedno energijo tudi za svoj prosti čas, za svoje zadeve, ki hočejo delati in tako naprej.
Tilen, iz vaših ust v kozja ušesa, bom rekla tako malo literarno, ne? Zelo lepo je slišati od mladih ljudi, bom rekla neko tako zelo spodbudno razmišljanje. Pričemer ste mogoče, bom rekla, skozi rožice povedal tudi to, da se ljudje različno staramo in da imamo različne zdravstvene in siceršnje težave. Eni veliko, ne, ker bom rekla ne vem kaj vse, drugi bistveno manj in seveda pri tej situaciji smo individualni, tako kot smo individualni pri marsičem. Odpiram razpravo, povabljam še druge. Izvolite.
Ja, jaz če lahko, Violeta Potočnik-Klinec. Jaz prihajam iz Doma za varstvo odraslih Velenje in bi zelo rada par stvari tukaj pokomentirala, ker v bistvu direkt iz stroke, jaz sem tista, ki sem velika zagovornica medsebojnih odnosov in absolutno verjamem v to, kot ste rekli, doktor Gorjupova, da na prvem mestu je odnos, je človek, je stisk roke, pa vendar ne moremo se na drugi strani izogniti tudi tehnologiji, a ne? In ergonomija, ta prispevek Tilnu mi je bil zelo všeč, zaradi tega, ker moram povedati, da poznamo, pa vsaj meni iz mojih izkušenj, pa eno drugo plat tega. Mi smo dom v celoti opremili z vsemi možnimi pripomočki, da zaščitimo zaposlene, da čim bolj uporabljajo vse, kar je mogoče, da ohranijo svoje zdravje. In vam povem, da smo vsaj 4 leta svojega časa namenili temu, da so res začeli te stvari uporabljati. Zato, ker nekako ne razmišljajo naprej, sploh mladi ne, da je treba paziti na svoje zdravje in če ne uporabljajo kakšne stvari, so hitreje gotovi. In tu smo res uporabili veliko truda, da smo prišli tako daleč, da so začeli dejansko uporabljati te stvari.
Bravo, super. To hkrati pomeni tudi usposabljanje kadra, ki že dela. To bi bila tudi ena zelo zanimiva tema, ko so nekateri prepričani, da starejši, ki so recimo 5 ali pa 10 let pred upokojitvijo, niso več sposobni se učiti ali pa se vanje ne splača vlagati, po domače povedano. Jaz sem oster nasprotnik tega.
Ja, res je.
Ja, hvala za praktični primer, z veseljem bomo še potem tudi katero rekli. Izvolite, kolegi, še naprej. Dajmo.
Mogoče bi še nekaj povedal,
Ja, Tilen, izvolite.
Kolegica. Ja, investiranje to je ena stvar. Zdaj problem je mogoče, zdaj za dome, za starejše osebe pač bi rekel, mogoče ni tak problem, ampak jaz pa vidim problem pri kakšnih ostalih organizacijah, proizvodnjah pa tako naprej, ker sploh ne vidijo mogoče tistega, ne gledajo na to kot investicijo, ampak samo en dodaten strošek. Zdaj, zakaj bi za delavce zdaj, ne vem, kakšne exoskele to ne dajali ali pa podloge za noge, to vidijo samo kot en dodaten strošek in meni se zdi, da v prvi vrsti pač treba te poslovodje, direktorje prepričati, da je to tudi za njihove delavce dobro na dolgi rok, da bojo oni s tem imeli manj izgub. Promocija zdravja na delovnem mestu je tudi en tak pojem, ki se tukaj pojavlja. Pa če se še malo na vas vrnem, kar ste omenili, ja, definitivno delovne obremenitve, vsak si je različen, vsak se pač drugače stara, vsak ima svoje probleme z zdravjem ali pa jih nima. Tlej v prvi vrsti bi rekel, da je tudi genetika do ozadja, tukaj se težko kaj pomagamo. Druga zanimiva zadeva, s katero se pa tudi dosti ukvarjam, so pa delovne obremenitve oziroma obremenjenosti. Koliko se zdaj človek počuti obremenjenega? Mi damo lahko vseh, koliko nas je tukaj. 89 izmed nas na isto delovno mesto, pa se bo vsak drugače počutil obremenjenega. Tudi ta subjektiven pogled se mi zdi tukaj zelo pomemben, a ne. Se pravi, kako zdaj to probati uravnotežiti. No, s tem se pa zdaj nekako probavam ukvarjati doktorsko, no, tako.
Super, Tilen, zelo radi bomo prišli ne samo na promocijo, ampak tudi na predstavitev. Ja, mogoče pa nekaj nismo še izpostavili, ne? V teh, bom rekla, neprevidljivih, unpredictable, bi rekli v angleščini, časih, ne? Kjer je v ospredje stopil kapital in ni v ospredju več človek, ne? Tega se recimo na teh področjih, ko delamo z ljudmi, želimo na vsak način izogniti. Ampak kljub temu kolegice iz domov za starejše, iz bolnišnic, pa še marsikoli drugod poročajo o tem, da ko nekdo da odpoved, ne, se v bistvu ne nadomesti z novim zaposlenim, ampak se delovne naloge porazdelijo na ostale, ne. To se pravi še dodatno situacijo. Zdaj, tem našim delodajalcem, nekaterim že prihaja do spoznanja, da vlaganje v človeka je tisto, kar jim bo tudi prineslo višji finančni ali pa kakšna druga oblika kapitala. Namreč mi smo v enem obdobju po osamosvojitvi zbezlali na tem področju, ne? Samo profit je bil v ospredju. Ampak znanje je tudi profit, zdravje je profit, pa še marsikaj, dobri odnosi so profit. In tukaj bi morali vsi mi na vseh naših področjih, kjer smo lahko dejansko prisotni, na to tudi glasno opozarjati. No, jaz sem zelo jezična, jaz to vedno govorim, vem, da tudi drugi to počnete in je to, bom rekla, prijetno. Zdaj, če dovolite, bom rekla, vprašala, ali naredimo kratek odmor ali gremo naprej. Kaj? Majda naprej? Dobro, gremo naprej. Potem bom vprašala, ali je pri nas prisotna, mislim, da je Gordana Šantek Zlatar. Ste prisotni? Bravo.
Tu sem.
Da, dobro. I will switch now to English for you, or that everybody will understand. Yes, you, Gordana, together with Marina Friščić, both you are PhD candidate at Alma Mater University. You prepared your presentation about rehabilitation of older adults after hip fracture in the Republic of Croatia. It's a very interesting theme. Not only in Croatia, but I do think all over the world, also in Slovenia. But however, please take, the floor is yours, Gordana.
Hvala. Jaz sem pripremila na hrvatskom, pa ne znam, ako mogu na hrvatskom prezentirati. Mislila sam da je jezik na izbor, pa ako ste svi za...
Pa jesmo, pa kako ne. Hoćemo razumjeti, ali idući put, Gordana, molim, pročitajte. Nije to moja kaprica, znate?
Ok.
Dobro.
Hvala. Evo, moja tema je znači rehabilitacija starih osoba nakon prijeloma kuka u Republici Hrvatskoj. Prijelomi kuka su jedan najvažniji javnozdravstveni problem u starijoj populaciji, nastaju kao posljedica padova kod osoba starijih od 65 godina, osobito kod žena sa osteoporozom i smanjenom mišićnom snagom. Znači, ozljeda je povezana s visokom smrtnošću, dugotrajnim invaliditetom i smanjenjem kvalitete života, a najvažnija je pravovremena rehabilitacija nakon kirurškog liječenja, zato jer na taj način se vraća funkcionalna sposobnost bolesnika. Postoje najčešći tipovi prijeloma kuka su prijelom vrata femora, zatim intertrohanterični prijelom, subtrohanterični prijelom iz razloga toga što su te ozljede najčešće kod starijih osoba zbog smanjene te mineralne gustoće kostiju i povećanog rizika pada. Ovdje sam stavila malo sličice da vidite intertrohanterični prijelom, pa prijelom vrata femura, zatim subkapitalni ili subtrohanterični prijelom, čisto da vizualno dobite dojam. Znači, već sam rekla da su žene sklonije prijelomima zbog osteoporoze. Ono što je jako važno je broj prijeloma kuka u Europi, zato jer se tu bilježi više od 500.000 prijeloma kuka godišnje. To je jako velika brojka koja proizlazi iz osnovne stvari, a to je da starimo kao čovječanstvo i da bude sve više problema koji su ove naravi. Ono što sam našla podatak je da procijenjeni broj prijeloma kuka za 2050. godinu iznosi 6,3 milijuna. Mi smo danas na brojci 4,5 milijuna. Nekak je to velika brojka i treba o tome pričati i treba na vrijeme raditi da se preveniraju ove stvari. Znači, javnozdravstveni problem u Republici Hrvatskoj su prijelomi kuka. Većina se javlja kod osoba starijih od 65 godina. U Hrvatskoj se bilježi nekoliko tisuća hospitalizacija zbog prijeloma kuka, a očekuje se i porast toga. To jako poskupljuje i to je jako veliki trošak za Hrvatski zavod za zdravstveno osiguranje i zato treba raditi na prevenciji. Znači, zašto je to važno? Zato jer su posljedice jako ozbiljne, a to su smanjena pokretljivost, gubitak samostalnosti, povećan rizik od komplikacija koje se mogu javiti i potreba za dugotrajnom rehabilitacijom i povećana smrtnost. Znači, ono što je tu sada još važno je da 20 do 30% bolesnika umre unutar prve godine nakon prijeloma kuka. Mortalitet vidimo da je jako veliki u toj prvoj godini, a najveći u stvari je od 30 dana do 6 mjeseci nakon te ozljede koja nastaje. Sad, algoritam rehabilitacije, znači nakon pada je vrlo važno detektirati, znači donijeti dijagnozu prijeloma kuka, hospitalizirati čovjeka, brzo ga operirati. Ono što je dalje jako važno je rana mobilizacija, potom rehabilitacija. Zašto? Da se postigne funkcionalni oporavak takvih ljudi i naravno nakon svega toga da se radi na sprečavanju ponovnog pada bolesnika. Ono što je najvažnije su rana mobilizacija, smanjenje boli, povećanje mišićne snage, poboljšanje ravnoteže i koordinacije, povrat funkcionalne sposobnosti i poboljšanje kvalitete života. Znači, ta rana naša rehabilitacija smanjuje komplikacije poput tromboembolije, pneumonije i dekubitusa, koje su jako ozbiljne komplikacije, a mogu koštati i života. Znači, ta rehabilitacija naša započinje 24 do 48 sati nakon operativnog zahvata. Program rehabilitacije prilagođava se vrsti operacije, općem zdravstvenom stanju bolesnika i naravno komorbiditetima, odnosno ostalim bolestima koje bolesnik već i ima. U ranoj fazi rehabilitacije vrlo je važna vertikalizacija, vježbe disanja, izometrične vježbe. U nekakvoj srednjoj fazi koja traje 2 do 6 tjedana, jačanje mišića, vježbe ravnoteže i trening hoda, a u kasnoj fazi funkcionalne vježbe, stabilizacija hoda i povrat svakodnevnim aktivnostima. Najveći napredak funkcionalni nakon prijeloma kuka se postiže tijekom prvih 6 mjeseci rehabilitacije. Znači, to nam je najvažniji period u kojem trebamo raditi na rehabilitaciji. Znači, ono sve nakon 6 mjeseci ima jako spor oporavak kod naših pacijenata. U Republici Hrvatskoj rehabilitacija se provodi kroz razne modele. Može biti u sklopu odjela, znači može se provoditi kroz bolničku rehabilitaciju. Imamo evo i sreću i mogućnost da se rehabilitacija može provesti u specijalnim bolnicama u Republici Hrvatskoj, to su takozvane toplice. Zatim možemo kroz ambulantnu fizikalnu terapiju i kroz kućnu rehabilitaciju, tako da fizioterapeut dolazi u kuću bolesnika, onih koji imaju nekakve kontraindikacije za bolničku ili tu specijalnu rehabilitaciju u toplicama. Znači, ono što je važno napomenuti da to sve ide kroz sustav Hrvatskog zdravstvenog osiguranja, znači da bolesnik, pacijent ne plaća ništa. Indikaciju propisuje operater, odnosno kirurg, traumatolog ili ortoped ili specijalist fizijatar. Tada ta preporuka ide na komisiju HZZO-a koja odobrava, znači komisija osiguranja koja odobrava rehabilitaciju, određuje vrijeme trajanja. U toplicama, odnosno tim specijalnim bolnicama, vrlo je važna hidroterapija, zato jer dokazano je da ima povoljne učinke na pokrete i da jača snagu mišića i da pospješuje i ubrzava oporavak i vraćanje funkcionalne sposobnosti. Evo to izgleda ovako, svi su sretni i zadovoljni kada se radi na ovakav način. Imamo nekoliko specijalnih bolnica u našoj zemlji, to su Krapinske toplice, Varaždinske toplice, Lipik, Naftalan, Crikvenica i Makarska. Najčešće rehabilitaciju odobre na 21 do 42 dana. Sad postoje različite i druge, osim hidroterapije, rehabilitacijske metode, bilo da se radi o kineziterapiji, elektroterapiji, magnetoterapiji ili radnoj terapiji. Uloga medicinske sestre svakako je uz ovaj stručni fizioterapeutski način rada, praćenje svakako zdravstvenog stanja, praćenje stanja u komorbiditetima, prevenciju dekubitusa, pomoć pri mobilizaciji i naravno educirati bolesnika i obitelj. Ono što je još jako važno da uopće ne dođe do tih padova su prevencija padova, ne samo u kućnim uvjetima, nego i recimo u bolničkim uvjetima. U tome bi trebali sudjelovati svi stručnjaci koji rade oko pacijenta, i liječnici, i sestre, i socijalni radnici, socijalni gerontolozi, fizioterapeuti, njegovatelji, obitelji, neformalni njegovatelji, naravno sam pacijent. Znači, u kućnim uvjetima treba osigurati uvjete, pomagala, okolinu, podršku, educirati pacijente, naravno i raditi jako puno na edukaciji o važnosti tjelovježbe u starijim osobama. Ono što sam rekla, znači ne samo misliti na padove u nekakvoj normalnoj kućnoj atmosferi, nego i na našim radnim mjestima, u bolnicama. Zašto? Zato jer se i tamo događaju padovi, zato jer ih osnovna bolest neke bolesnike ili demencija ili smetenost ili privremeni deliri promijeni njihovo psihofizičko funkcioniranje i oni ne znaju što rade, krenu, nemaju snage, može se desiti pad. Zato treba misliti na opremu, na pomagala, na ogradice, na podove, na osvjetljenja, na sve ono što bi moglo dovesti do pada i treba to prevenirati. Znači, apsolutno sam zagovornik tjelesne aktivnosti, prevencije pada i trebamo raditi na tome da ljudi postanu svjesni da se treba kretati, da treba raditi vježbe ravnoteže, da treba liječiti osteoporozu, da treba prilagoditi prostor i da treba svakako koristiti i pomagala. Evo ovako nekako izgledaju vježbe koje se provode znači bilo grupne, bilo individualne, bilo virtualne, bilo što, ali važno je da je čovjek pokretan i da radi na svojoj tjelesnoj kondiciji, na ravnoteži, na vježbama, mišićne snage, na balansima i da bude pokretan, funkcionalan i što je vrlo važno, samostalan.
Bravo vam.
Evo, u zaključku samo da znači trebamo razmišljati o prijelomima kuka, trebamo ih prevenirati, trebamo misliti na rehabilitaciju i ono što bih onak naglasila da je to multidisciplinaran pristup, vrlo, vrlo jako omogućuje bolju funkcionalni oporavak ljudi koji padnu. Hvala vam lijepa.
Ja, hvala vam. Hvala za predstavitev. Drugič, vljudno prosim, preberite, kaj piše, kaj je jezik. Velikokrat organizaciji, razumem, organizatorji ne dajo izbire. Tu ni taka demokracija, še manj pa svobode, ne? Vaš prispevek je bil zelo poln nekaterih medicinskih terminov, ne, za katere sem prepričana, da jih boste potem tudi v prispevku ali pa v naši diskusiji kasneje tudi malo, bom rekla, pojasnili, ker vsi nismo z tega področja specialno tako, kot ste vi. Ja, hvala lepa. Zdaj pa, now I'm calling Marina Friščič, who together with a former presentator is also the PhD candidate at our university, about triage of elderly people with hip fractures according to the Australian triage scale in emergency departments. The floor is yours. Marina, are you present? You are present, but we are not hearing you, Marina. Switch on. Marina, microphone. I'm not a policeman. Opravičujem se, ne želim biti policist, ne? Ampak neke stvari moramo skupaj. Marina, microphone.
Hello, everyone. I'm so sorry.
Yes.
I'm here.
Yes.
Can I please introduce my presentation on Croatia? I have slides on English, please.
Do it.
Do it. Thank you very much, Professor. One moment, please.
Yes.
I can share it.
Jure, lahko pomagate, gospa ne more deliti?
Mislim da će ići sad, profesorice.
Dobro.
Moram otvoriti prvu prezentaciju.
Padci so tudi zelo aktualne teme pri nas, ne samo pri nas, celo NASA raziskuje te zadeve. In nenazadnje, tako kot je Gordana rekla, situacija je tudi finančno, bom rekla, ne samo za sistem, čeprav tudi za sistem, ne, tu imate vi kar neke lepe prilike, ne, biti v zdraviliški bolnišnici do 42 dni je v Sloveniji skoraj da že misija impossible. Ne? Ja, Marina, bo šlo?
Ne mogu podijeliti, profesorice, opće evo, mislim da ću uspjeti. Jel vidite?
Da, ide, izvolite.
Okay, hvala. I would like to introduce myself. My name is Marina Friščić, and I would like to talk about triage of patients age over 65 with hyperfractures according to the Australia-Asian triage score in the hospital emergency department. Jel vidite dalje? Evo ga, želim predstaviti zapravo ovu svoju prezentaciju na način približiti hitnu službu u Republici Hrvatskoj koja prima zapravo više od 1.000.000 stanovnika godišnje. Ja radim u objedinjenom hitnom bolničkom prijemu i zapravo u ovoj prezentaciji želim reći da je sve veći problem i sve više pacijenata koji se sa tegobama prijeloma kuka staroj životnoj dobi javljaju u hitnu bolničku službu. Procjenjuje se da će broj prijeloma kuka u svijetu porasti s približno 1,7 milijuna slučajeva godišnje na više od 6 milijuna do 2050. godine. Ne znam, mi ide dalje. Što se tiče epidemiologije, rizični čimbenici prijeloma kuka, jedni od najvažnijih su zapravo godine. Rizični faktori su naravno osteoporoza, padovi starijih osoba, zatim nedostatak mišićne aktivnosti, odnosno snage, disbalans balansa, kronične bolesti te uzimanje lijekova. Više od 90% prijeloma kuka je rezultat zapravo pada. To su istraživanja pokazala. Što se tiče incidencije prijeloma kuka prema dobi, možemo reći da smo podijelili starije osobe u razdoblju od 65. do 85. godine života. Najviše naravno je onih pacijenata koji su u najstarijoj dobnoj skupini, više od 85 plus je zapravo 1200 incidencija na 100.000 stanovnika. Što se tiče samih kliničkih znakova, odnosno vitalnih znakova, tipični znakovi su jaka bol u području kuka, nemogućnost oslanjanja na nogu, skraćenje ekstremiteta te vanjska rotacija noge. Komplikacije koje su moguće to su delirium, zatim duboka venska tromboza, plućna bolest, pneumonija, dekubitus i mortalitet unutar prve godine života, što nije zanemarujuće, iznosi 20 do 30%. Što se tiče hitnog bolničkog odjela, on zapravo predstavlja ključnu ulogu inicijalne procjene tih pacijenata u sam bolnički sustav. Glavni ciljevi su zapravo da vidimo kakvi su vitalni parametri tih pacijenata. Vrlo važna je procjena boli starijih osoba, zatim stabilizacija tih pacijenata i brza dijagnostika, a mi koji radimo u hitnoj službi znamo zapravo koliko je važno brzo zbrinuti te pacijente na način da oni, ajmo reći, ulaze u naš sustav, kako bih rekla, što brže, jer znamo da su i dugačke su obrade pacijenata, a isto tako i da ti pacijenti naravno zahtijevaju skrb s obzirom na okupaciju boli i analgezije. Trijaža je zapravo proces klasifikacije tih pacijenata. Zapravo mi moramo prepoznati na trijaži kao medicinske sestre, koristeći ATS trijažnu ljestvicu, prepoznati najkompleksnije te pacijente. Zatim potrebno je da identificiramo životno ugrožene pacijente, da odredimo prioritet njihovog liječenja, te da na taj način da im smanjimo čekanje pacijenata. Ovo je zapravo trijažna ljestvica koja se koristi u Australiji, inače je u bojama, sad sam stavila čisto da se vidi. Trijaža 1 to su najhitniji pacijenti, životno ugroženi, trijaža 2 to su pacijenti koji mogu u hitnom odjelu čekati 20 do 10 minuta. Najviše pacijenata sa prijelomom kuka zapravo imamo u trijaži 2 i trijaži 3, a vidjet ćete da je to zapravo zbog same procjene boli. Što se tiče menadžmenta, odnosno algoritma, na koji način radimo tu trijažu, mi trijažu zapravo radimo na način da to traje otprilike 2 do 5 minuta za sve pacijente, pa tako i za pacijente s trijažom kuka. Mi ćemo zapravo njih trijažirati s obzirom na ljestvicu boli u trijažnu kategoriju 2 ili 3, procijeniti vitalne parametre. Vrlo važno je da ti pacijenti unutar zadanog vremena dobiju analgeziju, jer prijelom kuka je zapravo to je jedna od najjačih kosti, rekla bih, u organizmu i jako boli. Zatim potrebno je napraviti radiološku dijagnostiku i potrebno je konzultirati kirurga, odnosno ortopeda. Dakle, tretman za prijelom kuka starijih osoba bio bi idealan u 24 do 48 sati. No, međutim, vidimo da zapravo prema novim istraživanjima tek je svega nešto 15% pacijenata operirano unutar 24%, dok je 20% pacijenata operirano između dana do 2, odnosno 24 do 48 sati i 48 sati, znači 2 dana, otprilike 30% pacijenata. Svi dalje pacijenti zapravo duže čekaju na operaciju, što nije nikako dobro za pacijente starije životne dobi. Kao što sam rekla, znači s obzirom na stanje boli, ti pacijenti zapravo čekaju u trijaži otprilike 10 minuta. Što se tiče procjene njihove boli, jako nam je važna procjena boli, što znači od 0 do 3 da je to blaga bol, tada oni pripadaju trijažnoj kategoriji 4 i onda po pravilu ATS trijažne ljestvice duže čekaju na pregled. Ukoliko je njihovo određivanje boli otprilike 4 do 6 na ljestvici, tada čekaju otprilike pola sata, a ukoliko je izuzetno jaka bol, što sam napomenula da je to u većini slučajeva tako, zapravo oni idu u obradu odmah, jer je to mjesto prijeloma da li vrata femura ili tijela femura, odnosno glave femura, izuzetno bolno za pacijente. Što se tiče starijih osoba, moramo im uzeti u obzir na trijažu njihovi multimorbiditet, znači bolesti od kojih boluju, to su otprilike kronične bolesti, dijabetes, tlak, visoki kolesterol. Polifarmaciju oni uzimaju svi više manje dosta lijekova, jer naravno da su bolesni sa životnom dobi, znači to mogu biti različiti lijekovi koje sam već napomenula. Naravno da su te osobe sklonije kognitivnom oštećenju, a isto tako mogućnost postoji i delirijuma nakon operacije. Što je ključno za medicinske sestre, znači da oni procijene vitalne parametre starije osobe, da ih oni odmah u trijaži detektiraju, da dobro procijene tu bol i da ta bol zapravo se okupira na način da oni dobiju odmah riješenu tu analgeziju, jer tretman otprilike u odjelu traje kroz sat vremena do njihove hospitalizacije na odjel, da se procijeni funkcionalni status i da se procjenje visoki rizici za pacijenta, te da se odredi trijažna kategorija. Već sam rekla, znači to je otprilike trijažna kategorija, najčešće 2 ili 3, ovisno o njihovim vitalnim parametrima. Vrlo je važna rana identifikacija. Može se reći zapravo da novije studije govore o mortalitetu, o skraćivanju dana hospitalizacije i o pojavnosti komplikacija. Zašto je važno da starije osobe što manje ostaju u bolnici? Pa upravo i zbog komplikacija i mlađe osobe sklone su različitim infekcijama, a naravno da su i starije osobe podložnije i infekcijama, pneumonijama, urinarnim infekcijama, sepsama ili slično, tako da je zapravo cilj da ti pacijenti što prije budu procijenjeni u hitnom odjelu, zbrinuti i kad dođu na odjel da su što prije operirani, a navela sam zapravo i postotak tih operacija. Najidealnije bi bilo da su starije osobe operirane unutar 24 do 48 sata, kada je zapravo i najbolja šansa za njihov dobar oporavak. Evo, za zaključak bi rekla da je prijelom kuka zapravo važan naš javnozdravstveni problem u starijoj populaciji i da mi kroz zdravstveni sustav u Hrvatskoj koristimo australoazijsku trijažnu ljestvicu. Sa posebnom pažnjom obraćamo, odnosno procjenjujemo te pacijente i uzimajući u obzir sve njihove gerontološke i gerijatrijske promjene s obzirom na dob. I evo, nadam se da će i ovaj trijažni dio doprinijeti zapravo njihovom uspješnom ishodu liječenja. Evo ga, zahvaljujem se.
Marina, hvala. Samo ena pripomba iz vaših ust v božja ušesa tudi za Slovenijo, ne? Ker ta avstralska metoda, bom rekla, teh hitrih ukrepov kaže na to, zakaj je čas tako zelo pomemben. Ampak o tem bomo rekli kasneje v diskusiji nekaj več. Hvala lepa, Marina. Zdaj pa vabim gospo Suzano Mežnarič Novosel, ki je tudi naša doktorska kandidatka. I'm sorry, I will split to English. I'm inviting Mrs. Susanna Mežnarič Novosel, who is also PhD candidate at our alma mater university. She will present her title, Towards Equitable and Sustainable Long-Term Care in Europe, a Comparative Perspective. Susanna, please, the floor is yours.
Hello, dear Emeritus Professor Ryup, and hello to all my colleagues and others who are listening. Now, I will present you a comparative study within the framework of the Interreg project Centinos. This means a Center for the Development of Innovation in Social Care. This is a broad study, and it's not possible to present all of its methodological and substantive dimensions within 10 minutes. And therefore, I will focus on the three research phases, the key elements of the comparative analysis, and the main concluding findings relevant to the future development of long-term care in Europe. Okay, can you see my presentation? I think you can see. So I will focus on analyzing the quality and accessibility of long-term care. This study was about this, and systems across European Union member states. Particular attention was given to understanding how different welfare conditions, as well as political and institutional frameworks, shape the organization, accessibility, and sustainability of long-term care services. The research was structured in three consecutive and interconnected phases. The first phase involved a review of key European policy documents and an overview of the main characteristics of long-term care system in Europe. Then the second phase is focused on identifying and analyzing examples of good practice that demonstrate innovative and effective models of care provision. And the third phase synthesizes the main systemic findings divided from three analyses in order to better understand common trends and challenges within European long-term care systems. European long-term care systems are currently facing significant demographic changes. We know all this, and particularly population aging, and the resulting increase in demand for care services. For example, approximately 31 million people in the European Union require long-term care, and this number is expected to rise to approximately 38 million by 2050. At the same time, many countries are experiencing a gradual decline in the availability of informal care traditionally provided by family members and relatives. At the European level, the development of long-term care systems is also guided by important policy frameworks, such as the European Pillar of Social Rights and the European Care Strategy, both of which emphasize accessibility, quality, and sustainability of care services. Despite those shared challenges, substantial differences remain among countries in the organization of long-term care system. The Eurohealth survey distinguish between Nordic, continental, Southern European, and Eastern European models, which differ mainly in terms of the scope of public financing, the level of institutionalization, and the role of families and communities. Slovenian have a new long-term act, but they belongs to the group of countries where the long-term care system is still evolving and where services provision remains partly fragmented. Some minute or yes. Based on the review of European and long-term care systems, we developed a comparative analytical framework that includes several key dimensions. The first dimension concerns the types of long-term care services provided in different countries, including home care, community-based support, and institutional care services. The second dimension relates to financing mechanisms where European countries employ various combinations of public funding, social insurance schemes, and private or out-of-pocket payments. The third dimension addresses regulatory frameworks and quality standards that define the conditions under which long-term care services are delivered. And the fourth dimension focused on the accessibility and availability of services for different population groups, taking into account demographic, social, and geographical differences. And on this basis, it was also possible to identify common challenges and emerging trends in long-term care across Europe. The results of the comparative analysis reveal several important common characteristics of European long-term care systems. First, in most European countries, home-based and community care has become the dominant normative objective of social policy, as it supports greater independence of older adults and contributes to improved quality of life. Second, long-term care systems typically include a combination of different types of services, ranging from formal home care to semi-residential services and institutional care. Third, informal care continues to represent one of the central pillars of long-term care provision across Europe. And another important feature of European systems is the prevalence of mixed financing models, which combine public funding, social insurance schemes, and private or out-of-pocket payments. At the same time, significant differences remain between countries in terms of regulatory frameworks and quality standards. For just a minute. For example, home and community-based care is a policy priority, but you can see that access often remains limited. For example, fewer than 1 in 4 people aged 61 plus with care needs actually receive these services. Then also informal care accounts for approximately 18% of all long-term care provision in Europe. The next example is also that 1.7% of GDP 2019 will increase to 2.5% by 2015. So I mean, raising concern about the sustainability of financing. This is just some examples. Then, in this way, we, based on all this review for opinion examples, we also developed an operation definition of good practice in the field of long-term care. And we find that a good practice can be understood as a model of service organization or delivery that is effective, innovative, and sustainable in the long term. An important characteristic of good practice is their user-centered orientation, meaning that services are adapted to the actual needs of individuals and support greater levels of independence and dignity. In addition, good practice often contributes to improved social inclusion of older adults and to better integration between social and healthcare services. Yes, this is an example of integrated home care, which was also tasted in Slovenia. This is examples also from Slovenia and from Europe, where social and health services were coordinated in Slovenia, and the users received additional services such as physiotherapy, occupational therapy, and psychosocial support. These examples originate from pilot initiative that supports Slovenia's transition toward the new Long-Term Care Act and development of an integrated care system. But such approaches are particularly relevant for Slovenia today, while in many, for example, Nordic countries, similar integrated and community-based models have already been established for a longer time. And among these analyzing examples of good practice, several innovative approaches to organization long-term care identified. So as I told, in Europe, also in Slovenia, have some very good practices. And one of the most significant developments is the expansion of integrated home care models that connect social and healthcare services and enable more coordinated support from users. A single entry point systems is new for Slovenia. And also play an important role by facilitating easier access to different types of services. In some countries, a new professional role of long-term care coordinator has been introduced in order to connect different services providers and ensure the coordination of individual care plans for it, which is very important also from Slovenia and for now and our new long-term care act in Slovenia. Another important development concerns digital innovations, including telecare services, smart living environments, and various digital tools supporting home care. Also in Slovenia, when we are implementing our long-term care, we tasted some support, some technological support for older adults. It was very good for all these testing people. Beyond technological innovations, many good practices are also based on community-oriented and person-centered models of care. Then the examples.
Susanna, your time is running up.
Yes. I have concluding findings. Thank you. Thank you. So European long-term care systems remain diverse, yet they are increasingly confronted with common structural pressures. Among the most significant challenges are demographic aging, workforce shortages in the care sector, issues of service accessibility, and the long-term sustainability of financing. At the same time, strengthening home and community-based care, improving integration between social and healthcare services, and expanding the use of digital solutions are becoming central development directions. For the future development of long-term care systems, the establishment of comparable indicators, reduced evaluation frameworks, and the transfer of successful models across countries and regions will therefore be particularly important. And to conclude, the diversity of long-term care systems across Europe should not be understood as weaknesses, but rather as a valuable source of learning and innovation. By analyzing good practices and identifying common challenges, we can better understand how different systems respond to demographic changes and evolving social needs. If we aim to build sustainable and equitable long-term care systems in the future, stronger cooperation, shared knowledge, and continuous evaluation of innovative models will be essential. Sorry, thank you.
Thank you, Susanna, for your presentation. However, it was interesting to see that not only Slovenia, but in other countries are similar or in the other different approaches to the digital use in the care of older adults. So I have very pleasant information for you. I will not bother you anymore because director ordered me another role in today's digitation or some processes on the faculty. So I was very pleased. I was honored to roll this section, and I know that I am sometimes very demanding, very tired, but please don't understand that I had meant something bad with you. So farewell to you. And my role, I will take Dr. Natasha Standecker. Have a nice time, and with students, and I believe also with our colleagues from Cathedra of Social Gerontology. We will see us on Tuesday, March 17th in the morning. Have a nice time and goodbye.
Goodbye. Thank you.
Hello, everybody. Thank you, Professor Guriup. I suggest that we proceed with the next article, Digital Inclusion and Intergenerational Contendence Between Older Adults and Young People, a pilot study represented by Valentina Vincek, PhD candidate at Alma Mater Europaea University, Mariana Neuberg, Associate Professor at University Nord, Ivana Dvorski-Lackovic, lecturer at Fakultet Organizacije Informatike.
Microphone. Oprostite, ispričavam se.
Ovako, znači moja prezentacija bit će na hrvatskom jeziku, a zapravo u nekakvom sklopu svoje doktorske dizertacije napravili smo pilot istraživanje o digitalnoj uključenosti osoba starije životne dobi i mladi. Zapravo možemo reći da, samo malo, vidim da se ne mijenja. Ok. Znači, živimo u nekakvom paradoksalnom društvu gdje s jedne strane svjedočimo velikim tehnološkim svakodnevnim promjenama koje zapravo oblikuju svakodnevni svijet. Isto tako, svakodnevno, nažalost, u posljednje vrijeme svjedočimo i nekakvim ratnim događanjima koja zapravo isto tako koriste nekakve moderne tehnologije, no s druge strane, što se tu tiče međuljudskih odnosa, možemo reći da još uvijek tapkamo u mraku. I zapravo bi tu trebalo nešto učiniti, mislim da bi se u tom pogledu trebali mijenjati. Možemo reći da nam digitalne tehnologije zaista svakodnevno mijenjaju način komunikacije, isto tako i rada, ali i društvene participacije. I zapravo ta digitalna pismenost postaje ključna kompetencija u današnjem modernom društvu, no međutim, unatoč svim tim silnim naprecima još uvijek postaju značajne generacijske razlike u određenim digitalnim vještinama i baš zbog toga osobe starije životne dobi često puta budu izložene digitalnoj isključenosti. I zapravo nam ta digitalna uključenost postaje nekakav važan društveni izazov. Isto tako, učinkovit pristup smanjenju digitalnog jaza, rekli smo već je to međugeneracijsko učenje gdje zapravo bi osobe mlađe životne dobi trebale pomoći starijim osobama u osvajanju digitalnih vještina. I zapravo teorija te međugeneracijske solidarnosti naglašava važnost uzajamne podrške između spomenutih generacija. Također možemo reći da mladi generacija Z, možemo ih nazvati i digitalni urođenici, zapravo tu služe kao mentori u razvoju digitalnih kompetencija osoba starije životne dobi. A ono što se pokazalo da zapravo ti međugeneracijski programi mogu povećati socijalnu uključenost, smanjiti određene stereotipe i ojačati nekakvu društvenu koheziju. Znamo isto tako da Alportova teorija međugrupnih kontakata govori pozitivno o suradnji između dviju različitih skupina koje zapravo onda može smanjiti određene predrasude, a samim time i potaknuti pozitivne stavove. I zapravo su nam te digitalne edukacije temeljene na međugeneracijskom učenju predstavljaju važan alat za jačanje socijalnog društva. Samo malo. Znači, što se tiče metodologije istraživanja, proveli smo pilot istraživanje na uzorku od osoba starije životne dobi, 65 godina, gdje je bilo uključeno 58 osoba i mlađih osoba između 18 i 25 godine. Njih je sudjelovalo ukupno 66. Razdoblje provedbe je bilo između 27.9. i 28.10. na području Varaždinske županije. Za potrebe istraživanja kreirano su 2 strukturirana upitnika koja su sadržavala između ostalog sociodemografske podatke i željela su ispitati digitalnu uključenost, nekakve zajedničke aktivnosti, također nekakve predrasude i stereotipe. A pouzdanost samog upitnika testirana je Cronbach alfa testom gdje on za osobe starije dobi iznosi 0,815, a za mlade osobe 0,85. Rezultati nam pokazuju da je najviše osoba starije životne dobi sudjelovalo između 65. i 74. godine, a što se tiče mlađih, najviše ih je bilo između 20. i 23. godine, približno 70%. U obje skupine dominantan je bio ženski spol. Što se tiče osoba starije životne dobi, najveća je bila završena srednja škola, oko 50%, a zatim osnovna ili viša, dok su kod osoba mlade dobi to bili najčešće studenti iz područja biomedicine i zdravstva. Podjednako su bili sudionici iz sela i grada, a što se tiče osoba starije životne dobi, da li žive s mladima između 18. i 25. godine.
Ja vam se što vas moram prekiniti, vaš PowerPoint se ne miče. Dajte na PowerPoint. Dajte na cijeli screen.
Samo malo. Dobro, jel sad vidite?
Ja, meni se miče. Ja, sad je bolje. Hvala.
Sad je bolje, ok, dobro. Što se tiče nekakvog života s mladima, evo oko 40% osoba starije životne dobi je izjavilo da da, a što se tiče mladih, da li žive sa osobama starije dobi, 30% se izjasnilo pozitivno. Što se tiče nekakvog kontakta osoba starije životne dobi i mladih, svakodnevno je bio najčešći odgovor, a redovito 2 do 3 puta tjedno se izjasnilo 70% ispitanika, dok je kod starijih svaki dan, odnosno 4 do 6 puta tjedno se izjasnilo 60 do 70% ispitanika. Što se tiče nekakvog iskustva i percepcije jednih prema drugih, osobe starije dobi su se 60% izjasnile kao pozitivno, a 25% neutralno, dok je svega 15% izrazilo kao negativno iskustvo, dok su mladi većinom se izjasnili kao pozitivno, odnosno neutralno oko 70 do 75%. Negativno je bilo gotovo približno kao i kod osoba starije životne dobi, oko 15%. I zapravo obje grupe većina kaže da je iskustvo zapravo utjecalo pozitivno ili djelomično pozitivno na mišljenje o drugoj generaciji. Što se tiče nekakvih stereotipa, znači kod osoba starije životne dobi primijećeni su negativni stereotipi, visoko su ocijenjeni, gdje zapravo oni navode da osobe mlađe dobi previše koriste tehnologiju, nestrpljivi su, zanemaruju savjete starijih osoba, površni su i neodgovorni, dok su pozitivni stereotipi također bili ocijenjeni visoko i naglašavaju inovativnost, oni su budućnost društva i fleksibilni su. S druge strane, mladi osobama starije dobi isto tako su iskazali visoko ocijenjene negativne stereotipe, gdje naglašavaju da osobe starije životne dobi sporije uče tehnologiju, teško prihvaćaju promjene i ponekad su zahtjevni. Što se tiče visoko ocijenjenih pozitivnih stereotipa, navode mudrost, iskustvo, izvor savjeta i strpljivost. I ono što je tu zapravo zanimljivo, da postoji recipročni eđizam, gdje obje strane misle da druga grupa ima predrasude prema njima, odnosno stariji smatraju da ih mladi podcjenjuju, a mladi da ih stariji generaliziraju, i zapravo pozitivne percepcije možemo reći da su simetrične. Što se tiče korištenosti digitalnih tehnologija, osobe starije dobi najviše koriste pametne telefone, a nekakve platforme su Viber i Facebook, i vrijeme provedeno na tim društvenim mrežama otprilike 1 do 2 sata dnevno. Većina koristi osnovne informacije na društvenim mrežama ili zapravo uopće ne koristi, dok osobe mlađe životne dobi najviše koriste Instagram, TikTok, WhatsApp i nekakvih 2 do 4 sata dnevno. I zapravo tu opet vidimo da taj tehnološki jaz je najčešća prepreka i navode ga u 40 do 50% obje grupe. Zapravo su spremni i jedne i druge skupine na međugeneracijsku suradnju, i jedni i drugi se pozitivno izjašnjavaju u tom smjeru, i zapravo osobe starije životne dobi spremne su učiti o novim tehnologijama i željeli bi da ih mladi nauče o e-bankarstvu, o korištenju Worda i kako se koristi email, a zapravo mladi pokazuju spremnost podučavati ih tehnologijama i učiti, ali s druge strane učiti od njih životne vještine i tradicije. Ovo su neki od najčešćih predloženih aktivnosti, znači žele se zajednički družiti i provoditi određene aktivnosti, žele radionice gdje bi se razmjenjivala znanja, žele edukacije koje bi uključivale edukaciju o tehnologiji i nekakve online aktivnosti, odnosno igre. Najveće prepreke zapravo za obje skupine su nedostatak komunikacije, razlika u interesima i stavovima i to nekakvih 50 do 60%, predrasude je nedovoljno razumijevanje i kako sam već spomenula taj tehnološki jaz. Najveća korist za obje skupine je to jačanje međusobnog razumijevanja i smanjenja predrasuda i to u 70%, smanjenje osjećaja osamljenosti i povećanje društvene poveznosti oko 60%, razmjena životnih iskustava i vještina te učenje novih vještina oko 55% i za stvaranje prijateljstva oko 40%. I zapravo možemo vidjeti da ovo provedeno pilot istraživanje pokazuje da su odnosi između mladih i osoba starije životne dobi istovremeno obilježeni i pozitivnim, ali i negativnim stereotipima. Zapravo jedna i druga skupina prepoznaju vrijednost druge generacije, ali kako sam navela, prisutne su i određene predrasude i rezultati su u skladu s istraživanjem iz 2021. koje pokazuju da međugeneracijski stereotipi nisu fiksni i da se može kvalitetnim susretima i druženjima zapravo utjecati na njih. Također rezultati ovog pilot istraživanja upućuju na to da sama učestalost kontakta zapravo nije uvijek dovoljna kako bi se smanjile predrasude i da je od toga puno važnija kvaliteta samog druženja nego količina tih kontakata, što potvrđuje i istraživanje iz 2019. koje ističe da baš ti pozitivni i kvalitetni međusobni kontakti doprinose smanjenju stereotipa i razvoju povoljnih stavova. I isto tako spremnost sudionika na radionice, druženje i razmjene znanja u skladu je i s istraživanjem iz 23. koji isto tako pokazuju da su programi usmjereni na smanjenje eđizma, učinkoviti u ublažavanju predrasuda i poticanju pozitivnih međugeneracijskih stavova. Također ovo pilot istraživanje pokazuje da je eđizam između mladih i starijih recipročan i da je prisutan u oba smjera i zapravo znači da i mlađi i stariji prema drugoj generaciji imaju određene stereotipe i osjećaje da ih druga strana ne razumije u potpunosti. Također rezultati upućuju na tehnološki jaz koji zapravo u našem uzorku nije bio samo prepreka, nego se zapravo i pokazao kao moguća prilika za međusobno povezivanje. I zapravo to međugeneracijsko učenje i suradnja kroz tehnologiju može postati prostor razmjene znanja u kojoj zapravo mladi prenose osobama starije životne dobi određene vještine, a stariji njima s druge strane iskustvo i praktična znanja, što nas dovodi do zaključka da zapravo dobiveni rezultati podupiru ideju da su međugeneracijski odnosi obilježeni istodobno i prisutnošću stereotipa, ali i spremnosti na suradnju. Obje skupine ističu koristi povezivanja i pokazuju motivaciju za zajedničke aktivnosti, što nam zapravo sugerira da bi sve intervencije trebale biti usmjerene na međugeneracijsko učenje, digitalnu inkluziju i zajednička iskustva, što bi dovelo do smanjenja predrasuda i jačanje socijalne kohezije. A u praktičnom smislu to bi značilo da ovi rezultati podupiru razvoj programa koji ne promatraju mlade osobe starije dobi kao suprotstavljene skupine, nego zapravo kao generacije s različitim, ali isto tako s komplementarnim resursima. I završila bi ovu prezentaciju sa jednom slikom. Lani u Trakošćanu smo imali kongrese Zlatna dob i drugi dan tog kongresa smo imali međugeneracijsko druženje osoba starije dobi i mlađih koje se zapravo pokazalo jako kvalitetno i jako dobro. Evo, hvala vam na pažnji.
Hvala puno. Thank you very much. Our next speaker is Violeta Potočnik-Krajnc, who will present the paper titled Implementation of Deinstitutionalization in the Institutional Care of Residents of the Home for the Care of Adults Velenje. The stage is yours. Thank you very much. We see your presentation. You just need to put it in a whole screen and go with it.
Do you hear me now?
Yes, we hear you with your presentation.
Thank you. Thank
Yes,
you.
thank you very much.
Thank you. Dear colleagues, welcome and thank you for joining my presentation. My name is Violeta Potocznik-Krainz, and it is my great honor today to present the implementation of the institutionalization in institutional care at the Home for the Care of Adults in Velenie. Let me ask you, what makes a place feel like home? Is it the building, the services, the routines? Or is it something much more fundamental? Relationship, safety, and a sense of belonging. Today, I would like to share how one institution in Slovenia tried to answer exactly that question. I would like to share with you a story of a transformation. For almost 50 years, our home has provided institutional care for older adults in the center of the young city of Velenie. However, over time, we began to recognize something important. The traditional medical model we had been following slowly transformed our living spaces into something that resembled wards for the infirm rather than real homes. What was missing were the very things people need most: relationships, emotional safety, and human closeness. The realization led us to a profound conclusion. The future of care must move from functionals to relationships. Our original building reflects the thinking of another era. It was designed according to a classical hospital model at the time when the profession of social care was still developing and largely subordinated to medicine. But over the decades, the field of social care has evolved significantly. It has gained professional autonomy and introduced modern approaches that focus on individualization, personal dignity, and above all, the quality of relationships. Our vision for change began to take shape in 2010. We defined a new professional direction to transform the home into a modern relational community, something closer to a substitute family than to a traditional institution. We started with the river of life model and gradually developed our own approach called the culture of harmonized relationships. Our first steps included pilot implementations, strengthening soft skills among staff, and identifying our own vulnerabilities. Our goal was clear: to intensify the process of deinstitutionalization from within the institution itself. This journey eventually led us to the model of the culture of harmonized relationships, which has been recognized in Slovenia since 2013 as one of the most appropriate models for developing care practice. The model is strongly grounded in neuroscientific findings. It is based on the understanding that reviving positive memories helps create positive emotional states in older adults. And positive emotional states are essential for well-being, for dignity, and quality of life. At the heart of this model lies a very simple but powerful concept: relationship. Our focus is to build harmonized relationships at every very level, between residents and staff, among staff members, and between staff and leadership. Through authentic communication, respect, and emotional safety, we aim to create an environment that truly feels like a place of belonging. The ultimate outcome of this model is trust. Trust develops when three key principles are fulfilled: respect for the uniqueness of every individual, a working environment that engages employers personally, and alignment between our values and our actions. To support this vision, we reorganized the home into a smaller household communities, autonomous work teams, and a more personalized rhythm of everyday life. In this way, we try to make daily life as normal and meaningful as possible. However, implementing this model fully brought us to a major challenge. We discovered that the structure of our building was too weak for a partial renovation. The only safe professional solution was a complete reconstruction carried out in a single phase. This means something extraordinary. We had to relocate all 190 residents of our home. Our temporary home became Hotel Vesna in Topolšica. We rented 2.5 floors of double rooms and creatively transformed the wellness center into a kitchen, dining facilities, therapy rooms, and service departments. This enormous logistic operation was planned in just a week. For our staff, it was a professional challenge to maintain quality care and stability even in crisis conditions. Through this entire transition, the culture of harmonized relationships remained our guiding principle. All decisions were made through dialogue and mutual respect. Most importantly, residents themselves were actively involved in the process. They were introduced to the temporary location and were even able to choose their own roommates. Their needs, wishes, and individuality were always our highest priority. Another major challenge was reorganizing our long-established teams. We had to divide them into two large teams for the temporary location. When allocating staff, we carefully considered existing relationships, social cohesion, and professional competence. The result was remarkable. During the 1.5 years of relocation, the team structure did not change even once. This stability provides extremely important for our residents. Meanwhile, our building was complete. This time, the architecture itself was designed according to the culture of harmonized relationship model. We wanted the physical environment to naturally support relational life. When it was time to return home, we organized the relocation gradually and carefully. Each resident was given 30 minutes for the transition, ensuring a calm and respectful move. And when they arrived, our reception team welcomed them with a rose. Today, we can confidently say that the true deinstitutionalization within the institution has been achieved. The institutional logic has been replaced by a sense of home and belonging. Our architecture now supports small household communities, personalized living spaces, and clear rhythms of everyday life. But the real drivers of this transformation are our stable and autonomous teams who take responsibility for the life of the community. Today, our residents live in a small, recognizable communities surrounded by people who know them, who trust them, and who share everyday life with them. We no longer function simply as an institution. We function as a relational and dynamic life community. And perhaps the clearest proof that this model works is this: staff shortgates are currently unknown to us. Today, once again, our residents do not live in an institution. They live in a community, a place where people know each other, trust each other, and share everyday life. And perhaps the strongest proof that this model works is very simple. Where relationships grow, staff shortgates disappeared. The institutionalization based on people, on team. And I learned that if you want a motivated and accomplished team, you must invest in them, support their decisions, discuss things openly, and help them grow. In that way, the residents of our community are very happy. Thank you for your attention.
Thank you very much. I would like to call the next author, Urška Kunčić, PhD candidate at Alma Mater European University, to represent her paper titled Social Gerontology and the System of Long-Term Care in Disability Protection in Slovenia.
Hello.
Hello, Urška.
Can you hear me?
Yes, we hear you. You can continue. You can go on.
Hello, I'm very sorry. I have some issues with the technology. Is now okay?
You just need to share the screen and then you can go on with your presentation.
Yes, but it's something with the, I don't know, system. It break and then I go out of this plenary. So
You had started to share your screen now. I guess it should be okay. Now it's okay.
I hope it will work because something is not good with the signal. I'm sorry.
Okay.
Okay. Hello, my name is Urshka, and I will present to you today social gerontology and the systems of long-term care and disability protections in Slovenia. I'm the Master of Social Gerontology, and now I'm the third year student of the doctoral study program Social Gerontology. I work in the system of long-term and disability protection in Slovenia, so it's very important that we all know what is here today the biggest problem for the elder people. Slovenia is facing a significant aging of the population and also increasing needs for older adults and needs for people with various disabilities. Therefore, several areas have become key fields of social policy. Social gerontology professional field that studies aging, quality of life in older age, and ways to support active participation of older people in society. Long-term care, a system of service and rights for people who needs ongoing assistance with everyday activities due to age, illness, or disability. Disability protection, a set of legal opportunities, protections of rights and supports for the social and labor inclusions of people with disabilities. Together, these three areas form the foundation of social security, dignity, and solidarity in modern society. When we talk about population aging, we often think about the future, but the future is already here. The number of older people is increasing and the need for support is growing. At the same time, an important question is how society can ensure a dignified and good quality of life for everyone, including people with eliminations. Social gerontology and the role of the social gerontology. We often hear the question, what is social gerontology? It's a multidisciplinary field that studies the aging process of individuals and their social positions in society. It includes examining the social, psychological, cultural, and economic aspects of aging. The focus of active aging, social inclusions, and preventing the social exclusions of older adults. This refers to the social aspects of gerontology, not just the health or biomedical side, but also how to ensure quality of life, social services, support networks, and the participation of older adults. The curriculum includes topics from social work, gerontology studies, several service organizations, and methodology, ethics, and elder care, but it also includes communications, service management, and technologies for aging. In Slovenia, social gerontologists are recognized with the social welfare qualification system by the SOC as part of the social welfare sector. Here is picture, but it's in Slovenian, and a social gerontologist can take the professional exam in social welfare and administrative procedures, enabling the managed service and make official the decisions. Where can social gerontologists work in Slovenia? Employment in other profiles, it's in healthcare, hospitals, or rehabilitation centers, centers of social works, organizations, public sector, nursing homes, private service, or in researches or educations. Working as a social gerontologist abroad due to the global trend of population aging, there is a strong demand for gerontology professionals in the EU. Scandinavian countries, North America, and beyond. As a social gerontologist can work in institutions for older adults, projects, organizations, research of aging, services centers, nursing homes, daycare centers. Or opportunities also exist in the interdisciplinary teams, collaborating with the medicine, technology, and urban planning to develop innovative service such as a smart housing, e-care, and telemonitoring for older adults. Here is one picture for risk factors monitoring, medications, and symptoms of monitoring. And now the long-term care. What does long-term care mean? Is for people who do the illness, age-related threatening disability or loss of functionality needs assistance from others with basic and supportive daily activities over an extended period. A long-term goal slide template is from 2024, from January 1st, right? It's been a right to family caregivers. In the 2025, from July 1st, right to long-term home care, including e-care services and services to support and maintain independence. From 2025, from December 1st, rights to the institutional long-term care, full day care in nursing homes, day-long care, cash benefits, and the subsistence care. In the future, 2028 is so supposed to funded by mandatory letters insecure co-payments 10 to 20% may start in 2028. Receive general information, scope of home care services, monthly hours by category. Category first is 20 hours, category 2, 30, 3, 60, 4, 80, and the biggest one is category 5. This is 120 hours. This is daily based on 3-4 hours by day for one older adults or the youngest, because long term is from a year 18 and up. It have not upper number. Nursing home looted the fees over the only accommodation and meals. Cash benefits available from December 2025, and law promotes community integration, entry points and the system, and easier access. Challenges and opportunities. Among challenges is the Long-Term Care Act does not provide clear legal grounds for decisions, and as also noted by the Health Insecure Institute of Slovenia, transferring current nursing home residents into the long care system will be a complex process. Explaining services like e-care and good coordination between health, social, and local essential, along with the developing system to monitor and quality. Disability protection in Slovenia. Several laws regulate disability protection, like ZSVI, ZIMI, personal assistance, social welfare. Slovenia has ratified the UN Convention of the Rights of Persons with Disability. The goal is like the opportunity, social inclusions, access to service and protections for persons with disability, rights and services for persons with disability in Slovenia is disability status, disability allowance, care and assistance allowance, personal assistance, supervised employment and care, special work centers, a choice of family helper, and communication allowance. Disability coordinators employed at Centers for Social Work, the Directorate for Persons with Disabilities, went to the Ministry of Labor, Family, Social Affairs, and this is a MDDSZ. It coordinates programs, analyzes and supports NGOs in their field, and social welfare inspiration and social inspiration. So is supervised of such as regulations. Challenges and current issues, assessment and status issues, services. Then is very important for like access across regions and adopting the new needs and standards and cross-sector coordinations. Conclusion: social gerontology, long-term care and disability protection build a modern, inclusive society. The goal: improve quality of life for elderly people. Slovenian new law is very important for elder peoples and for workers in the social gerontologies. Like in this last words says, social gerontologists play a key role because of empathy and understanding of life in different stages for aging. References, and thank you for your attention.
Thank you, Urška. I would like to open now the discussion session. Please, if you have any questions, any discussion, anything, any thoughts that you would like to share with the rest of the panel, just please go ahead. Does anybody have a question for any of our authors?
Yeah, I do have a question for Urška, if I can.
Yes, just go ahead.
Yeah. Do you know any cases where social gerontologists are involved in the e-care development?
Jaz imam en predlog, če lahko, Nataša, mislim, da bi bilo fajn, ker smo prej imeli razpravo v slovenščini, če lahko še zdaj, da bodo mogoče
Okay.
malo razumeli tudi študenti.
Hvala, Urška. Lahko razpravo v slovenščini, če ste imeli prej, seveda.
Ja, Nina,
Prosim, če
lahko še
postavite
enkrat
vprašanje v
ponoviš.
slovenščini.
Ja, seveda lahko. Mogoče Urška veš, a je kakšni primer, ko so gerontologi vključeni v e-oskrbo v razvoj teh naprav?
Ja, hvala Nina za vprašanje. Ja, vem za primer, dejansko, kot sem prej omenila, v primerih, ko gre za ta širši model, ne same e-oskrbe, naprimer pri dolgotrajnih oskrbah, tukaj so zdaj tudi vključeni ne samo pri nas, tudi pri tujih, ne, partnerjih, socialni gerontologi, vendar ni še tako zdaj to aktualno, recimo pri nas, ker se je komaj sedaj začelo, ampak so predvsem pri raznih, recimo, ko so te padci sedaj zelo aktualni ali pa ti riziki, pri tem se največkrat, ne, recimo pri raznih teh raziskavah in v tem vključujejo socialni gerontologi, kajti že samo ta individualni pristop je na splošno pomemben pri e-oskrbi, ne samo za paciente, tudi samo vključenost socialnih vidikov in pa starejših odraslih v socialno, zdravstveno, tudi na splošno in okolje na domu in pa tudi v domu, torej v institucionalnih raznih institucijah.
Najlepša hvala, Urška. Zelo izčrpno, hvala.
Hvala, Urška. Ima kdo naslednje vprašanje? Če ne bi imela samo vprašanje za gospod Vesno Potočnik. Vesna, me slišite? Violeta, pardon, ja, pardon.
Ja, slišim.
Imeli ste zelo lepo predstavitev, me pa nekaj zanima. Videla sem tam na slikicah, da imate dvoposteljne sobe, kar je čudovito, me pa samo zanima, kako potem poskrbite za zaščito intimnosti, recimo v dvoposteljnih sobah, ker nisem videla, da bi imeli paravonde ali pa kakršnokoli drugo pomagalo, recimo, ki bi omogočila, da pač se zagotovi intimnost v nekih trenutkih.
Takrat, ko je recimo ta potreba, mislite takrat, ko je recimo nega ali pa
Ja,
ko
recimo.
se, lejte, pri tem v bistvu imamo premične te španske stene, drugače pa takrat, ko je recimo, ko se nekdo poslavlja, ko gre za zadnjo fazo, imamo na voljo sobice na vsakem nadstropju za paliativno oskrbo, ampak veste, da smo v zadnjem letu pa pol, odkar smo v novi hiši, v bistvu trikrat doživeli, da stanovalci niso želeli, tudi če je stanovalec, ki se je poslavljal ali družina želel, da se umakne, so tisti, ki so z njim v sobi, se raje umaknili, ker so želeli, da on ostane na svojem mestu. Tako da nimamo težav z zagotavljanjem tega. In mislim, da to tudi bazira na tem našem modelu kulture usklajenih odnosov, ker se res dosti pogovarjamo o tem, delamo v tej smeri in teh težav ni.
Zdaj pa imam še eno drugo vprašanje, in sicer, če se par priseli, ker jaz pač tudi poznam malo te sisteme teh postelj in to, če se par priseli, pa imate vi dvoposteljno sobo z temi posli, kako pol zagotovite, da lahko par spi skupaj?
To sploh ni težava, zaradi tega, ker ali damo postelje skupaj, se pravi te postelje, čeprav je potem reža vmes, drugače pa po kulturi usklajenih odnosov, po modelu, ki ga delamo, lahko del sobice opremijo stanovalci tudi sami, z lastnim pohištvom. In nekateri pač želijo svojo posteljo, in do takrat, dogovor med nami je, do takrat, da to gre, do takrat, da se ne rabi pač celotna nega nekoga, ki zahteva pristop z treh strani, da lahko zagotavljamo dobro nego, do takrat pač lahko imajo po svoje. Tudi k steni potisnjeno posteljo, vse do takrat, dokler ne nastopi trenutek, ko rabimo vse ostale strokovne stvari zagotoviti.
No, vprašam zato, ker obstajajo te francoske posle, ki so prav narejene za, v bistvu, da so lahko pari v dolgotrajni oskrbi. Recimo, lahko vsaka je posebej nastavljiva, vsaka je posebej, vseeno pa so skupaj. Tako da sem mislila, če imate v bistvu kaj v tej smeri.
Ne, teh še nimamo, zaradi tega, ker smo zdaj 17,5 milijona dali sredstev za to, da imamo novo hišo in zdaj počasi te stvari dodajamo.
Zelo veliko delo ste opravili, tako da vam čestitam.
Hvala, najlepša hvala.
Še ima kdo kako vprašanje? Če ne, bi zaprla ta panel in bi šli 10 minut na pavzo, pa začnemo ob 12, tako kot je po programu začetek naslednjega panela. Start the next one. I would like to call our next authors, Branka Jarc-Kovačič, lecturer at Higher Vocational College, School Center Kranj, Tilen Medved, PhD candidate, Zvone Balantič, professor at University of Maribor, Faculty of Organizational Science, to introduce the paper titled Digital Ergonomics Across Generations, Health Challenges and Awarenesses in a Long-Lived Society. You can just go on and start your presentation.
Okay, welcome again. I hope you're enjoying this conference. This is my second presentation, which I'm giving on behalf of Branka Jarc-Kovačić, and she was the co-author as well as my mentor, Professor Dr. Zvone Blantić. And for this research, we tried to look at digital ergonomics across generations, how they compare between younger and older adults, and so on. So, yeah, we're still looking at, we mustn't say elderly, but older people, yeah, like your colleague said earlier. So, why this matters? Work, as we know, is becoming more digital. We have more work from home. We're even behind our computer screens on weekends, like today, on this Saturday. And also, not only more digital, but working lives are also longer. So, yeah, if people live up to, let's say, 75 of age, that's around 4,000 weeks that you get to live. And why this pizza is here? Because I want to give you an interesting analogy and then tell you why I think it's important. So first of all, if we divide our life into 12 pizza slices, we get around, let's say, 1/3 of our life is for school and work, education, and so on. So that's already 1/3 of our life gone. Then another 1/3 is for getting ready to sleep and sleeping. So that's another 1/3 gone. And then 1/3 is for shopping, let's say, taking care of others, doing things at home, okay? Another slice is for traveling and transportation. This is either to school or to work, to holidays, whatever. And then another slice, second to last, is for preparing food and eating. This also takes some part of our lives, okay? And then the last one is for leisure activities. This is basically your free time that you get to spend. This is either recreation, on TV, surfing the internet, whatever you want to do. So yeah, this analogy is interesting and all, but what I want to maybe focus on is that, okay, if we try to look at our life behind the screen and try to draw that out, we will see the following. Just give me a second. If we take a look how much of our lives is spent behind screens, we would find out that around 5 slices of our whole life is spent behind screens. And I find this very troubling because it leads to techno stress, it also leads to digital fatigue. And how do we spend our time behind screens? Either by computer screen, either from work or from home, behind TV, on our telephones. And that's why we decided to take a look into this matter to see how we can maybe lower that, or how digital ergonomics also takes place when so much of our lives is behind screens. So yeah, generations may face similar load levels, but notice different risks. More on that later on. So if I continue, do younger and older adults differ in perceived physical and digital ergonomics exposures? This was the first question, which also goes in line with Industry 5.0, which is very human-centric and sustainable. And we're not trying to be sustainable only for the environment, but also to the health of the worker. That's also an important part. How do we link work and digital habits, and do they differ by age? So we divided adults into 2 groups, and also how do these 2 groups evaluate digital ergonomics as a preventive approach? So yeah, we got 111 field surveys, field questionnaires. They came from different backgrounds, and we divided them by, like I said earlier, younger and older adults, below 35 and over 35. This was done on Enka, Arnes Enka, and we took a look at some different interesting stuff. So here we can see daily screen exposure, which was more than 4 hours, but this is just for work. So I guess, like I said earlier, this number even grows the more if we take into account our free time as well. And if we take a look next, what we have is the results of the physical work factors of ergonomic loads. We can see that many they are quite similar to one another. but we can see some differences in, let's say, reaching beyond optimal reach, or let's say here working with arms raised above shoulder level. This is work that is done more by younger adults. Okay, if I continue, then we also have digital work-related ergonomic loads. Here, I can tell you that for the mean for the young adults was around 2.34. For older, it was 2.20. So younger do experience a little bit less, a little bit more digital work-related loads. Similar to here, the mean is 2.85 for younger adults and 2.58 for older adults. Here we can see, let's say, the use of mobile devices, cognitive overload. Ergonomics is also has, like I mentioned in my previous presentation, a cognitive aspect to it, and also visual fatigue. So here we also divided into 3 parts: physical symptoms, and then also vision, head, eye-related symptoms. So maybe here the most prominent ones are the dry eyes, blurred vision, maybe some even headaches, someone younger generation. So here I'm going to try to give you a proactive measure which you can help yourself with. If you maybe heard before the 20-20-20 rule, this is basically that every 20 minutes you take a 20-second break and look 20 feet away. 20 feet away is around 6 meters. So maybe I'll take 20 seconds off my presentation to try to do this task with you, okay? If I maybe manage to do it. So let's take 20 seconds off and take a look into, let's say, through your window to restrain your eyes. I mean, to understrain your eyes. Okay, the timer ran out. Hope it worked, fortunately so. Okay, yeah, the next, but also important thing we looked at was the perceived association between health symptoms and work. This was mainly answered as yes or probably yes. So as you can see here on the percentages. And also we try to evaluate the ergonomics of as a preventive measure. So some long-term work ability, well-being, trying to reduce health risks, also trying to put ergonomics into education. Those were all on a Likert scale from 1 to 5 and were quite important as well. So maybe to finish off, do not be too long, some key takeaways. Both generations report meaningful physical and even higher, especially nowadays, digital loads. We're all quite under, like I said earlier, techno stress, digital fatigue, and so on. So it's nice to take some time off our day, go into the nature and do something off screen. Also, the differences are more about which risks stand out rather than the overall level regarding our looked at age groups. And also, yeah, symptoms, like I mentioned earlier, cluster across body, eyes, cognitive overload, and yeah, most of people link them to habits, either work habits or private life habits, free time habits. And yeah, ergonomics works best when it includes work design, norms, principles that you have to follow via ergonomics, and also education in the field. So it's not just like ergonomic tools, chair and desk fixes. Maybe you have like a stand-up table at home. That's also good, but it must also be educated upon and included into our everyday lives, not just work, but also at home. And yeah, if you have been, thanks for listening and thank you for your attention. I hope I was in time.
Thank you for your very interesting presentation. As the next author, I would like to call Anna Hribar-Podkrajnšek, PhD candidate from Alma Mater Europaea University to represent the paper with title Nature and Dementia Care, a narrative literature review on green spaces, participation, and dementia-friendly environments.
Hi, everybody. Do you see my presentation?
Yes, with your presentation, you can go on with it.
Thank you. Thank you so much. Well, today I will be presenting a narrative literature review about nature and dementia care. Just a second. Okay. I'm working in Arboretum Ovčji Potok and I'm also forest therapy practitioner, and I'm leading forest therapy for older adults in past 3 years. But in Arboretum Ovčji Potok, I'm also part of a Blue Cane Modra Palica study group that was created a couple of years ago by Dr. Zdenka Čebešek-Travnik. And we are at the moment promoting, and also we developed memory path designed for people with dementia and for their caregivers. And while we are preparing this memory path, so many questions arise. And for example, just I will give you a couple of examples how we can encourage so that memory path is actually used. And another thing is how the caregivers can influence inclusion and participation. Another one is how the accessibility, wayfinding, and sense of safety, how can this shape the participation of people using the memory path. And the last one is also very important, how people with dementia actually experience nature and what meaningful activities should be included in memory path. All these questions and many others, these were actually these practical questions from the field that actually served as a starting point where, and actually idea of making this narrative literature review about dementia, care, and nature. And just few sentences about the memory path so that you will understand my motivation. The path is 1,000 meters long, and it takes about 1 hour of slow walking, and it's safe and easily accessible even for those with walking difficulties. That means it's accessible with a wheelchair. And what we did, we actually trained volunteers that can that can take participants they can accompany on the trail, on the memory path. And you can see these are just spots that you can stop and engage with nature in Arboretum on this path. Well, I also created this, I found this key thematic domains from my narrative literature review that I will be presenting you. So the first one is really important, how people living with dementia experience nature. And Owens actually said that nature bypasses this cognitive decline and engages the person directly through bodily sensations. That means that the focus in nature is shifts from memory to experience life in the moment, to experience nature with the body. That means from cognition to the body, the shift. And Owen also gives us 3 dimensions of experiences nature. Again, this multisensory stimulation through bodily feelings creates feelings of peace. While we are experiencing nature, also it gives us sense of self and identity. And actually, experiencing nature can be connected to can connect actually nature provides a space that we connect to others, and what is really important in non-verbal communication. Another author said that, Mandy Cook said that nature environments attract attention effortlessly and actually provides a rich sensory experience that also brings us to Owen and the shift from cognition to the body. What that actually means for our memory path, that means that it's not just a walking path from A to B, but also we included sensory rich and also creative activities that actually support this embodied experience, that we connect, actually people with dementia connect to nature through their senses. The next thematic domain is actually that shifts towards preventing a shrinking world. Well, actually, due to cognitive decline, outside world could become unpredictable for people living with dementia. That means that people abandoned out of home activities and their world shrinks into four walls. And author Claude Hurry actually found out that visits to nature and recreational spaces are the most frequently and rapidly abandoned. And he also gave us some main barriers, such as fear of getting lost, noise, and uneven paths, and so on. And so being out in the world also breaks that really important thing is breaking this isolation of four walls. And it's one, just a second. One participants in this research said that when we are sitting in the park on the bench, we feel like regular people while doing that. What that actually means for our memory path? Well, walking along the memory path actually reduces isolation and enables individuals to re-engage with the community and their surroundings. That means that a participant on the memory path and their caregiver, this participant is no longer like a patient, but simply would feel like just a visitor, normal visitor in Arboretum Volčji Potok. The third thematic domain, it's all about caregivers. Well, people with dementia rarely visit nature alone, and their caregivers are assumed they have this role of gatekeepers upon whom every successful outgoing trip depends. But caregivers actually are anxious and could be overprotective. Because they can experience this high level anxiety regarding potential risks during out-of-home activities, such as falls, getting lost, and so on. But what is really interesting is that this anxiety is highly prevalent, even if the person with dementia has never actually experienced these issues in the past. And consequence is that they remain more in their homes. And what actually this means for our memory path? Well, memory path must not be adapted solely for people with dementia, and we have to think of also caregivers. And only easy to use environment reduces the caregiver's burden and anxiety. And one solution that when we thought about caregivers, we trained these volunteers, companions who can guide people with dementia independently. That provides a free time for caregivers to go around for Arboretum Volčji Potok, or trained companions can safely accompany both the pair. That means people with dementia with the caregiver on this memory path. The fourth thematic domain, it's all about how supportive outdoor environment should be. Stapley gives us two levels of accessibility. First is physical accessibility. That means barrier-free environment with level paths, benches, essential infrastructure such as like toilets, also bar in the environment where they can rest and have a coffee. And another level is cognitive accessibility. That means the environment that is easy to interpret. Another concept that I found really interesting is dignity of risk. That means that rejecting overly sterile supervision that gives support environment, that supportive environment must safely facilitate autonomous and free exploration, restoring the person's dignity, that person who lives with dementia. Another thing is safe and active contact with nature. For example, Borella offers horticulture sensory points like raised garden beds and herbs that are planted in. And what that means for our memory path in Arboretum, actually we thought of the benches in shades, clear waypoint identifications, and we actually put it the blue bench that you can see on the picture. This is actually the point if a person gets lost, and all people working in Arboretum knows this place. So it's also part of the safety issues. And also this blue bench is very popular among people. And beside that, there is a literature about dementia, and it's more just for people with dementia. And when we were developing our memory path, we also thought of the calming rest stops, and one of them is close to Red Maple Lake, where they can watch the lake and animals, and they can have this calming place to rest. And just a second. The fifth thematic domain, it's all about inclusivity, human rights, and destigmatization. Access to meaningful outdoor activities is not merely a therapy, but I think personally, I think it's a basic human right, access to nature for people living with dementia. And people with dementia have also the right to social participation and the freedom from discrimination. Their visible presence in public spaces actively challenges and reduces stigma. This is really important. Rejecting the creation, Marsh also actually pointed out that we should not be creating dementia-only spaces, and the goal is inclusive public spaces that enable us intergenerational connections and uphold the dignity of risk that I was talking about. What that means for our memory path, that means this is more than just infrastructure. It is a powerful social message to the world. Arboretum becomes, with this memory path, a space of destigmatization, restoring the place for people with dementia and in society as full citizens through this, also through the blue cane walks for a well-being memory path that we are conducting every second Sunday in Arboretum Oči Potok on this memory path, and these blue cane walks are open to the society, open to the public, not just for people with dementia, but everyone who is interested in this our project and beyond. And I also found some research gaps while I was reading the literature. I found that research primarily focus on institutional settings, and there are very few solutions for unstructured leisure time of people who still live in their home communities. This is one thing that is really important to address. Another one, research, the overlooked young onset dementia. That means people who are younger and physical active individuals with dementia, there's a lack of understanding about their needs and also shortage of appropriate outdoor activities tailored for them. Another research gap is connected to anxiety, personal needs of family caregivers, as they are gatekeepers, as I said before. And studies mostly examine caregiver burden in the later stages of the disease and overlooking the preventive anxiety caregivers experiencing regarding independent outgoings and their own needs for respite. And what that means for our arboretum? Well, actually, our project breaks new ground. We are creating a safe public space for community dwelling individuals living with dementia, while also actively addressing the fears and personal needs of their caregivers. And actually, we are opening a space for debate, and we are actually also working with non-governmental organizations and other experts, not just on people with dementia and their caregivers, but also now we are thinking of developing several paths for people who are deaf and blind people, people with different life challenges, as Arboretum Oči Potok wants to be a park that's accessible for all citizens of the Europe and the world. So thank you. And I'm open to discussion and the questions.
Thank you very much. I'm looking forward to visit your project.
We are open.
Because it is very interesting. And now I would like to welcome our next representative, Vilma Alina Postic-Bezenček, PhD candidate from University of Maribor Faculty of Law, to explain us more about intergenerational knowledge and the aging hunter, cultural dimensions of later life engagements.
Hello.
Hello.
I have a little bit trouble sharing the PowerPoint presentation, so doesn't go.
What is your trouble?
When I click on share, it doesn't. I don't see it. I think you don't see it also.
We don't see it either, but we have our IT technician here.
Yes.
We can see it. Yes, now we can see it.
Okay.
Just
okay,
go
okay,
on
okay.
thread and close it.
Share. Okay, now you see it, probably.
Okay. Yes.
Okay, great.
Just go on the presentation, on the whole presentation.
Yeah. Slideshow from the start.
You can yes.
Continue to share.
No, you're
okay. Hello again. My name is Vilma Alina. I come from the University of Maribor Faculty of Law as the PhD student. Today, I would like to present you a little bit on passing knowledge from older hunters to the next generation, a little bit different topic, intergenerational knowledge and aging in hunter-gatherers society. The topic connects anthropology and gerontology because it shows how older individuals remain important members of their communities through knowledge and transmissions. Rather than becoming socially inactive with age, elder hunters often take on roles as teachers, mentors, cultural leaders, so they stay involved in the society. Why elder knowledge matters? Hunting traditionally hunting in traditional society requires much more than physical strength. It involves complex ecological knowledge that takes many years to learn. Hunters must understand animal behavior, migration patterns, environmental signals, and seasonal changes. Because this knowledge develops slowly over time, older hunters often possess the deepest understanding of the environment. One of the anthropologists, Richard Lee, explains that expert hunters have extraordinary knowledge of animals and landscapes, and this knowledge is critical for the survival of hunter-gatherer communities. And all the hunters often know migration routes, weather patterns, and animal habits, and all of these they proceed and to learn the younger hunters. One of the case studies of the Hadza hunters is one of the examples from Tanzania. One of few remaining hunter-gatherer societies. Among the Hadza, boys begin learning hunting experience and skills at a very young age, often around 10 years old. How they do that? They accompany all the hunters on hunting trips where they observe the nature, how they experience the weapons, they track animals, how they move quietly, and they give the older tradition to the young people. This is not only the case in the Hadza hunters, but also in the modern society, in the modern type of hunting, falconry, and all other tradition that should be put to younger people. Through this process, knowledge is passed down informally through daily activities rather than formal teaching as we do now. Learning by observation. Observation is one of the most important ways knowledge is transmitted. Younger hunters watch elders carefully during hunts and gradually learn how to interpret environmental signs such as footprints, broken vegetation, animal sounds, animal behavior, strategy, and anthropologist Barry Helvet notes that children and hunters gather societies learn mainly by participating in adult activities. And these activities are at the moment taking part also in Celje, in the ferry of Hunter Ferry and others. There are 5 of them when the ecosystem, the animals, the tradition is presented to the public, to the young people. And this process allows practical knowledge to develop naturally over time. One of the case studies is also scent tracking skills. This is another important example that comes from Southern Africa. These people are famous for their advanced tracking skills. Hunters, for example, can interpret extremely subtle environmental clues to determine an animal direction, speed, and condition. And this is really very difficult, and it's important that this tradition goes on, that young people learn, and that it doesn't go to waste. These skills require years of practice and are usually taught by experienced elder hunters. And researchers explain that tracking knowledge is led through long-term mentorship and experience with expert hunters. In all this, very important is mentorship and apprenticeships. Older hunters also serve as mentors for young hunters of the community. They teach practical skills such as weapon use, tool making, hunting strategy, ecology. And for example, younger hunters often rely on elders during their first independent hunts. Elders guide them and develop them and help them interpret difficult situations. And this mentorships helps younger hunters to develop confidence and practical knowledge. And one of the case studies is also Inuit knowledge. In Arctic environments, elder knowledge can literally mean the difference between life and death. And among the Inuit people, elders teach younger hunters how to travel safely across the sea ice, predict weather patterns, and locate seal breathing holes beneath snow. And many anthropologists, among them is Yuli, emphasize that storytelling and shared experience help pass down knowledge about the land and animals. This knowledge has developed through generations of interactions with harsh Arctic environments. And storytelling, for example, storytelling and oral tradition is also important method of passing knowledge through younger generation. Elders often tell stories about past hunting experience that we do in the community when we gather from different occasions. Elders often, these stories include lessons about successful strategies, dangerous situations, environmental changes, cultural values, and through storytellers, young hunters learn not only technical skills, they learn values, ethical responsibilities related to hunting. And also environmental knowledge is very important. All the hunters also possess extensive environmental knowledge. For example, among the Aceh people of Paraguay, elder hunters teach younger members how to identify animal sounds, understand forest ecosystems, and recognize movement patterns in the dense forest. Researchers by anthropologist Michael Gurven shows that ecological knowledge continues to increase with age, even when physical hunting abilities decline. And gerontological perspective, from gerontological perspective, elder hunters demonstrate what is known as an active or productive aging. Although their physical abilities may decrease, they remain socially engaged and continue to contribute to their communities. This supports also many theories such as activity theory and continuity theory, which suggests that older adults maintain life satisfaction by staying involved in the community, in meaningful social roles, and helping younger people to develop. What are the modern challenges? Today, many traditional knowledge systems face challenges, and hunting is one of them. Urbanization, globalization, and changes in ecosystem and educational system often reduce contact between younger generation and elders. And as a result, opportunities for traditional knowledge transmission may decline. This raises concerns to loss of valuable ecological knowledge and cultural dimension. And In conclusion, the transmission of knowledge from older hunters to younger generation is essential for the survival of hunter-gatherer societies. Elder pass down skills, I said, ecological knowledge, cultural values through observation, mentorship, storytelling, and from the perspectives. These examples show that aging doesn't mean that older people should withdraw from the society. It means that instead of that, we should include older people to continue to play a very important role in our life as teachers, as leaders, as mentors, and intergenerational knowledge transfers strengths the communities and ensures cultural continuity. That is in short from me. Thank you. If you have any questions.
Thank you very much. We will do as usual the discussion and question section at the end of the panel. I will introduce by myself the next paper, who have is written, also authors are Natasha Standeker, Sonja Horvat-Grielands, PhD candidate from Alma Mater European University, both Nesha Odabash lecturer from Ankara Yildirim Beyazıt University. I will just start to share my screen and hope this everything works well. Okay. The title of the next presentation is IT and Robotic Solutions in Nursing and Social Care of Elderly Adults. We did a systematic literature review. And we, oh, sorry. I would like to introduce at the very beginning why this topic matters, because population is aging, it's increasing pressure on nursing and social care system, demographic pressure because of the growth of population 65 plus. The older population are growing fast globally, and more long-term support is needed. Care will be always every time more complex due to multimorbidity, frailty, and dementia, and it will be more monitoring and coordination needed. And staff, we have globally workforce shortages in field of elderly care, long-term elderly care, and community elderly care. We do have, like, for the last 10 years, and especially after Corona crisis, persistent staffing gaps and need for sustainable care delivery is growing. Technology is being positioned as a strategic response. Digital tools can extend monitoring, improve coordination, and support psychosocial care, but evidence is still fragmented across settings and intervention types. That's why we decided to do a literature review. We wanted to answer which interventions type dominate, which outcomes are reported, clinical, psychosociological, and original effects, and what are the implementation barriers, ethics, workflow, staff readiness, data protection. A central aim of the study is to synthesize high-quality empirical evidence on how IT and robotic solutions are used in elderly care already, what outcomes they produce, and what makes implementation succeed or fail in real-world practice. We use Prisma-guided screening with stricter post-2020 quality filters. We did search the articles published in Scopus, PubMed, Medline, Web of Science, EA Explore. We did we wanted to found systematic searches across 4 databases. We search after title, abstract, and full text relevance review. Filter quality was Scopus indexed with impact factor and English, and we have include 9 studies entered the qualitative synthesis. Eligibility criteria were older adults 60 plus, interventions 80 based on robotic solutions in nursing social care, study type as already said, empirical, quantitative, qualitative or mixed methods, time window from 2020 onward, exclusions, reviews, additional acute only hospital studies, non-English full text. Narrative synthesis was used because design, interventions, and outcome measures were highly heterogeneous. What the evidence base looked like, we have found 33% of articles from the field of IT-enabled solutions, and 67% of all literature was robotic solutions. Care settings represented home and community care, nursing homes, long-term care, hospital dementia care, smart home, and mixed older adult populations. Randomized and pilot trials, observation studies, feasibility studies, single case monitoring, and co-design user-centered research were taken as methodological mix. Okay, findings from the field of IT-enabled solution. The strongest evidence was for clinical and service use support, especially when digital tools were embedded in coordinated care pathways. We have divided them in 3 main groups: clinical and monitoring gains, reduced hospitalization, AD visits, better symptom tracking and chronic care monitoring, and potential support for aging in place. Organizational gains, more structured communication and care coordination, data-informed planning and risk detection, and support of efficiency and long-term care workflows. But benefits are conditional, and they need pathway integration and staff response capacity. Telemedicine uptake can fall because of reimbursement or staffing, and infrastructure matters as much as the technology itself. Technology alone is not enough. Value appears when the intervention is connected to real follow-up, staffing, and care processes. Key finding, social assistive robots. Robotic evidence was narrower than the IT literature and was concentrated around social assistive robots, especially Paro in dementia care context. Paro and other social assistant robots were used mainly to improve psychosocial well-being rather than to automate clinical tasks. Engagement and interaction, higher engagement in activities, more social participation in several settings, mood, comfort, and sleep, signals of benefit for mood and positive effect. Some studies reported improved sleep outcomes. Agitation and medication, some reductions in agitation were observed, and lower behavioral medication use in selected settings. Important qualifier, effects varied with facilitation, exposure dose, caregiver involvement, and practical issues such as maintenance or storage. What determines whether implementation succeeds? Across both IT and robotics, effectiveness depends less on the technology itself and more on the conditions around it, like the user acceptance, privacy and trust, perceived usefulness, non-intrusive, understandable design, workflow integration, staff training, fit with routines and staffing, and capacity to act on digital alerts, ethics and governance, data protection, transparency and consent, and clinical oversight and safeguards. Bottom line, safe and sustainable scale-up requires readiness in people, processes, and governance, not only access to devices. Implications for nursing and social care. The review points toward a hybrid care model in which technology extends capacity but human care remains central. And as you see on current slide, hybrid care model can be built up with four main stones. What technology adds? Monitoring, detection, coordination, and selected psychosocial support. Where value is strongest, when intervention feed workflows and are linked to follow-up actions. What staff still provide is judgment, relationship, ethical oversight, and tailored care decisions. Strategic implication, prioritize design, training, and governance over maximal automation. For policy and practice, the message is clear. Technology should be introduced as part of care system redesign, not as a standalone fix. And I'm coming to the end of my presentation with some take-home messages. The study showed that we have in field of IT and robotic solution in long-term care two dominant domains. IT-enabled care tools and social assistive robots define the current evidence base. Benefits are real but conditional. Clinical, psychosocial, and organizational gains depend on context and implementation. Human care remains central. Technology should complement, not replace caregivers and professional judgment. Scale up needs readiness, training, workflow fit, ethics, and data protection are prerequisites for sustainable adoption. Further research should move towards larger trials, longer follow-up, and stronger attention to ethics, equity, and digital inclusion. Digital robotic and innovation should not replace care relationship, but enhance the quality and sustainability of elderly care. Thank you very much for your attention. And now I would like to call the next authors, Matea Buzina, Tanita Knežević. They are both PhD candidates from Alma Mater European University to represent us the paper with the title Aging in Contemporary Culture, Challenges and Implication for Social Gerontology.
Dobar dan svima. Ja ću prezentirati na hrvatskom. Matea Buzina, sa kolegicom izradili smo rad na temu starenje u suvremenom društvu, izazovi i perspektive unutarnje gerontologije. Pardon. Dakle, što znači stariti u 2024. godine, odnosno
dajte na
u
cijeli
21.
skript, dajte na cijeli ekran jer mi vidimo samo oni mali dio. Dajte na cijeli ekran i počnite samo povrh.
Da, pokušala sam, ali imam nekih problema.
Ok, ako ne, probajte samo ako ide PowerPoint. Ako možete da predstavite slajde.
Pardon, mislim da ima nekih problema sa vezom. Jel me čujete?
Čujemo vas, probajte samo ako vam idu slajdovi da vidimo, da vas možemo pratiti. Ok, u redu.
Dobro, hvala. Dakle, što znači stariti u 2026. godini, odnosno u 21. stoljeću? Dakle, starenje je danas više od biologije. Starenje je kulturno konstruirano i usvoje, nije samo fiziološki proces. Danas se događaju brojne demografske transformacije, odnosno Očekivanja su da će do 2050. godine čak 30% stanovništva Europe biti stariji od 65 godina, odnosno da će prvi puta u povijesti broj osoba starijih od 65 godina premašiti broj djece mlađe od 5 godina. Dakle, ta dugovječnost danas je rezultat napretka medicine, javnog zdravstva i životnog standarda. Osim toga, svjedočimo transformaciji životnog stila. Starije osobe danas sudjeluju u društvu, dakle sudjelovanje starijih osoba danas u društvu bitno je drugačije nego je to bilo kod prijašnjih generacija, upravo zbog rapidnog razvoja tehnologije. Osim toga, nailazimo na izazove unutar sustava. Javlja se pritisak na mirovinske, socijalne i zdravstvene modele koji su dizajnirani za mlađu populaciju. Također, današnje moderno društvo nameće nam ideal active aging, odnosno aktivnog starenja, koje je zapravo Svjetska zdravstvena organizacija 2002. godine prezentirala putem svoje javne politike za promicanje aktivnog starenja. Odnosno, njihova politika je zapravo bila da se pruža starijim osobama da poboljšaju kvalitetu života. Međutim, ta paradigma aktivnog starenja danas je krivo interpretirana i vrlo često utječe i omogućuje uspon i širenje kulture savršenstva. Stoga danas zapravo imamo jedan paradoks. S jedne strane imamo ideal aktivnog, zdravog i produktivnog starenja, a s druge strane zapravo se razvija ageizam, stereotipovi i društvena marginalizacija. Stoga danas se zapravo više, umjesto da se promovira socijalna inkluzija, odnosno da se radi na socijalnoj inkluziji starih osoba, fokus se većinom prebacuje na to kako izgledati mlad, kako ne bi zapravo bili teret društvu. Autori Albertini Vignoli navodi kako se u današnjoj popularnoj kulturi širi svijest da je starenje relativan koncept koji nadilazi kronološku dob. Stoga ne čudi da je zapravo brzi razvoj anti-aging medicine početkom 20. stoljeća, čiji je cilj zapravo intervenirati na proces starenja putem lijekova, kozmetike i regenerativne medicine. Osim toga, danas se zapravo suočavamo sa izazovom socijalne vidljivosti starijih osoba, što je zapravo test naše sposobnosti da vidimo tu stariju osobu u cjelini, a ne samo njezinu kronološku dob ili recimo medicinsku dijagnozu. Dakle, uloga socijalne gerontologije bi bila da se razvije znanstveni okvir za razumijevanje starenja kao proživljenog iskustva, a ne samo biološkog propadanja. Kada govorimo o društvenoj konstrukciji starenja, dakle, društvena konstrukcija dobi zapravo se razvila unutar socijalne gerontologije krajem 20. stoljeća. Autori Powell and Hendricks ističu da starenje nije samo skup bioloških činjenica, već je zapravo društveno određeno, a dakle, društvo zapravo određuje svojim normama, zakonima i putem medija što znači biti star. Autorica Margaret Gallet u svojoj knjizi Aged by Culture navodi da nas društvo zapravo danas stari kroz sustavna očekivanja i slike o propadanju koje internaliziramo. Odnosno, naša nas kultura stari kroz sustavne priče o gubitku i nepoželjnosti puno prije zapravo nego počinje naše fizičke promjene. Osim toga, danas je raširen subjektivan osjećaj mladosti, dakle pojedinci se osjećaju mlađi od svoje kronološke dobi, čime slabe veze između godina, zdravlja i životnog stila. Danas bi zapravo velik imperativ trebao biti na osjećaju važnosti kod starih osoba, jer je to ključ konstrukcije identiteta u starosti kod starijih osoba, odnosno da budu percipirani, da su cijenjeni i da su potrebni drugima, što je vrlo važno za njihovu psihološku otpornost. Dakle, socijalna gerontologija je zapravo potrebna danas ne da liječimo starost, već da izliječimo društvo od stereotipova koje oduzimaju starijima dostojanstvo. Kada govorimo o demografskom imperativu, dakle o svijetu koji zapravo danas stari, a slabi mladost, svakako trebamo naglasiti, odnosno spomenuti autoricu Lindu Outcalt, koja je u svojem radu Aged by Popular Culture navela nekoliko važnih činjenica, a to je da mediji i popularna kultura zapravo promoviraju kult mladosti koji starenje prikazuje kao jedan negativan proces, što je zapravo posljedica, odnosno temelj te profitabilne anti-aging industrije danas. Također, razvija se neoliberalna ideologija, odnosno ona se danas širi, a govori o tome, dakle, da starije osobe su same odgovorne za održavanje svojeg zdravlja i mladolikog izgleda. Osim toga, široko se promoviraju digitalne ljepote u Hollywoodu putem takozvane CG tehnologije za digitalno pomlađivanje koje nam pružaju nerealnu sliku vječne mladosti na ekranima. Stoga je autor Antonio naveo da danas još uvijek postoji jedna vizualna stigma starenja u toj vizualnoj kulturi, odnosno vizualnim medijima, pa su znakovi starenja poput recimo bora, sive kose, koje se povezuju s bolešću i propadanjem, dok se uspješno starenje izjednačava s imitacijom mladosti. A anti-aging medicina zapravo pokušava tu starost popraviti i ne shvaćaju kao jednu fazu života. Dakle, ta stalna izloženost negativnim prikazima navodi te starije osobe da one internaliziraju stereotipove, što kod njih dovodi do osjećaja nevidljivosti i gubitka društvene vrijednosti. Ageizam i digitalna marginalizacija. Dakle, u medijima se javlja paradoks pozitivnog starenja, zato jer se s jedne strane slavi uspješno starenje, odnosno medicina slavi uspješno starenje, dok s druge strane mediji, dok se istovremeno sugerira da je bolest ili loš izgled zapravo isključivo odgovornost pojedinca. Autori Rosales i Fernandez navode da su starije osobe danas isključene iz digitalnog narativa i da se pretpostavlja da zapravo oni ne znaju koristiti ili ne razumiju novu tehnologiju, stoga se oni ne spominju kao aktivni korisnici, već kao netko ko kasni u svemu tome. Također, dizajn tehnologije danas je više usmjeren mladima, odnosno ti algoritmi i sučelja danas su zapravo napravljena na način da zanemaruju potrebe i navike starijih korisnika. Autori Los i Ivan su 2022. Definirali jedan pojam, vizualni ageizam, koji zapravo govori o tome da je to društvena praksa koji je nastao zbog društvene prakse podcjenjivanja i stereotipnog prikazivanja starijih osoba, odnosno da mediji izravno oblikuju način na koji zapravo mi doživljavamo starost, odnosno da oni odražavaju društvenu praksu. Autori Ruben i Ingran proučili su načine na koji se starije osobe prikazuju na društvenim mrežama, pa su oni pretražili zapravo TikTok, vrlo popularnu društvenu mrežu TikTok, hashtagom OKBoomer, koja je bila viralna tijekom 2019. godine i uočili su da je zapravo velika većina tog sadržaja vrlo ageistična. Autor Makita je proučio diskurse na Twitteru i uočio kako je tema starenja prihvaćena samo uz ideal ljepote, odnosno van toga dominira medicinski okvir i starije osobe su viđene kao pacijenti ili kao objekti skrbi, a ne ravnopravni sudionici. Stoga je autor Antonio predložio dizajn za dinamičku da se može koristiti u medijima, odnosno da se uvode mnoštvo različitih prikaza starosti kako bi se razvila ta homogenost stereotipova. Poput recimo pro-age kampanje od Dava iz 2007. godine gdje su koristili starije osobe kao modele. Dakle, zaključak ovog rada bi bio da danas u suvremenom društvu nalazimo taj paradoks. S jedne strane imamo medicinu koja slavi dugovječnost, a s druge strane imamo kulturne narative i digitalne medije koje marginaliziraju taj proces starenja. Dakle, mediji i društvene mreže danas prihvaćaju starije osobe samo ako one imitiraju mladost i ako se uklapaju u ideal aktivnog starenja. Isto tako, anti-aging industrija danas tretira starost kao bolest koju treba liječiti i popraviti. Stoga postoji potreba za stvaranjem inkluzivnijeg društva za sve generacije. Ja sam ovdje predložila neke od mogućih načina. Dakle, pokušati sa dekonstrukcijom kulta mladosti, dakle na način da se smanjuju medijski narativi koji slave isključivo mladost i koji marginaliziraju starije osobe kao nevidljive ili nefunkcionalne. Da se poveća, odnosno poboljša međugeneracijska solidarnost nasuprot sukobu. Umjesto digitalnih socijalnog isključivanja da se izgrade pozitivne veze. Da se poveća digitalna inkluzivnost, znači da se osigura digitalna pismenost za bolju socijalnu uključenost starijih osoba. da društvo i mediji zamijene zastarjele stereotipe o starenju kao bolesti sa multidimenzionalnim prikazima. I u konačnici, dakle, da starije osobe da budu priznate, odnosno da budu cijenjene i da se osjećaju potrebne. I na kraju, dakle, da se stvori pritisak na medije i institucije i da počinju promovirati starenje kao jedan prirodan i ravnopravan dio životnog tijeka, što zapravo starost i jest. Hvala.
Hvala. Our next author is Urška Bošnjak, expert, SINT. She will introduce us the paper titled Psychosocial Symptoms of Older Adults Receiving Palliative Care.
Dobar dan. Se slišimo?
Slišimo se.
Slišimo. First of all, I would like to thank Alma Mater Europea for the excellent organization of this year's conference. I would also like to express my sincere thanks to Natasha Standeker for her excellent moderation of this panel in the field of social gerontology. Please just let me know if my presentation works.
You're sharing your presentation, you just put it on the whole screen maybe, and let's check if your presentation works. If you can move the slide.
Works?
Just put it on the whole screen. Na zeleno stisnite, da bo cel ekran. Povečajte na cel ekran.
Ampak ga imam.
Mi ne vidimo.
Je prav.
Je prav, ok.
V redu je.
Ok, jaz ne vidim. Nevertheless. You can start your presentation.
Thank you. So this presentation begins with a simple question. What causes the greatest suffering in older adults receiving palliative care? Let me allow a few opening words. Most people would immediately think of physical pain. However, researchers increasingly show that psychological, social, and spiritual distress can be just as significant and sometimes even more difficult to recognize. Most people would immediately think of physical pain, but palliative care is defined as a holistic approach to the treatment of patients with advanced and incurable disease. Clinical practice often still focuses primarily on physical symptoms. As a result, psychosocial aspects such as loneliness, emotional distress, social isolation, or spiritual concerns experienced by older adults may remain insufficiently recognized. However, although palliative care is defined as a holistic approach to the treatment of patients with advanced influence the quality of life and overall well-being of patients living with advanced illness. An important theoretical foundation of this approach is the concept of total pain, introduced by Cicely Saunders, which emphasizes the suffering is multidimensional and cannot be understood just as a physical term. This perspective forms the starting point of my research, which explores how psychosocial distress in the palliative care of older adults is recognized and addressed in clinical practice, and how it influenced the overall quality of care and quality of life. So the thesis was how the psychosocial symptoms in the palliative care are recognized, monitored, and addressed in clinical practice. Palliative care improves the quality of life of patients facing lifetime illness and provide support to their families. Although palliative care is based on a holistic approach, attention in practice is often focused primarily on physical symptoms, while physiological symptoms such as depression, anxiety, grief, and social exclusion may be insufficiently recognized. Older adults are a particularly vulnerable group due to the illness is often accompanied by loss of independence, loss of roles, and social connections, which can intensify their emotional distress. The purpose of my research was to gain insight into the experience of professional staff working in palliative care and to understand how psychosocial symptoms influence the quality of life of patients, how influence the healthcare and social professionals and family members involved in the care system, care process. The study therefore explores how healthcare and social professionals recognize psychosocial distress and how symptoms are addressed in everyday clinical practice. The study was using a qualitative research design. Data were collected through 15 semi-structured interviews with professional staff involved in palliative care adults. Participants included healthcare and social professionals who regularly work with patients in palliative care. The research used qualitative content analysis, which enabled a systematic and structured examination. The analysis followed four-step data preparation, coding, category development, and interpretation of findings. So the analysis shows that psychosocial symptoms such as loneliness, grief, and anxiety are extremely common among older adults receiving palliative care. Participants emphasized that psychological distress is very connected with psychical symptoms. In many cases, psychosocial pain can intensify physical discomfort, supporting the concept of total pain in palliative care. There were five main categories identified through the analysis. First, symptoms in older adult. Two, recognition and impact of social pain. Three, the role of social support. Four, psychosocial impact on others. Five, the concept of holistic palliative care. The use of similar vocabulary across interviews suggests shared understanding among professionals of the challenges faced in palliative care, including loneliness, depression, anxiety, and pain. The findings were that effective palliative care requires more than just relieving physical symptoms. Psychological and social dimensions of suffering must be addressed. Psychosocial symptoms such as loneliness and social isolation significantly influence patient quality of the life and can also affect family members and the healthcare social professionals. The results highlight the importance of holistic approach to palliative care, and attention should be given to psychosocial needs and emotional well-being of palliative care. The study also points to systemic challenges and emphasizes the need of improved training of healthcare and social professionals and stronger integration of psychosocial support into everyday practice. So my keywords were palliative, older adults, psychosocial symptoms, social support. Oh, sorry. Psychosocial supports and social pain. So the psychosocial symptoms represent an important and often overlooked dimension of suffering in palliative care, especially among older people. The findings show that psychosocial symptoms significantly influence patients' quality of life. Social support acts as a protective factor, and holistic palliative care must include psychological, social, and spiritual dimensions. Palliative care is much more than relieving physical pain. To ensure high quality care, it's essential to consider the psychosocial needs of the patients. There is a need for greater recognition of psychosocial symptoms, systemic improvements in clinical practice, and further research in this field. Thank you.
Thank you very much for that interesting presentation. We are moving toward our last presentation, represented from my dear colleague, Dr. Mihaela Kezsmant, Assistant Professor at Alma Mater European University. She will represent the paper titled Social Effects of Older Adults, Participation in Study Circles in the Local Community. Manuela, I'm looking forward to your presentation. Mihaela.
Thank you. Okay, just a minute. Okay. Can you see?
Yes, we see your presentation. Just turn it in whole screen and
Okay.
presentation format.
Okay.
Yes.
Hvala. Jaz bom imela tole predstavitev v slovenščini, se pravi, predstavila bom socialne učinke sodelovanja starejših v študijskem krožku v lokalni skupnosti, se pravi v študijskem krožku, ki smo ga tudi organizirali. Cilj tega prispevka je, da predstavimo pomen vseživljenjskega učenja za starejše odrasle, predstavimo študijski krožek kot neformalno obliko izobraževanja, da predstavimo pomen socialne vključenosti in razvoj socialnega kapitala in predstavimo sam študijski krožek, pisane voščilnice za skupnost in učinke vključevanja starejših v smislu, kaj so pridobili na področju sodelovanja, kako je na področju osamljenosti, doživljanja in pa kakšen je bil prispevek v lokalni skupnosti. Vseživljenjsko učenje, vemo, je kontinuiran proces, poteka skozi celotno življenje in vključuje seveda različne oblike formalne, neformalne in tudi priložnostne oblike učenja. V študijskem krožku, ki ga bomo predstavili, gre predvsem za to neformalno obliko učenja. In seveda to prispeva k ohranjanju kognitivnih sposobnosti starejših, prinaša veliko psiholoških dobrobiti in tudi ima učinek na osebnostnem področju. Vsekakor pa pomembno vpliva tudi na socialne odnose med starejšimi odraslimi, hkrati aktivira staranje in kakovostno življenje. Študijski krožki so pri nas organizirani kot neformalna oblika, gre pravzaprav za neko prostovoljno udeležbo, študijski krožki so brezplačni, koordinira jih Andragoški zavod Slovenije, Ministrstvo za izobraževanje pa je tisto, ki krožke tudi financira. Gre pravzaprav za skupinsko učenje, kjer se učijo tako udeleženci eden od drugega, kakor tudi se učijo s pomočjo oziroma preko mentorja in tudi odnos med mentorjem in udeleženci je nekako horizontalen. Na koncu se predstavijo te izkušnje tudi v lokalnem okolju. Hkrati je pa ta zanimivost, da gre za aktivno sodelovanje članov, kajti člani načeloma, če je le mogoče, sami pripravljajo tudi vsebine, jih načrtujejo in tudi podajajo ideje, ki pravzaprav želijo neko določeno znanje pridobiti. V letu 2024 je bilo v Sloveniji 92 izvajalcev študijskih krožkov v 69 občinah, za lansko leto pa se je to število že povečalo, ampak uradnih podatkov še ni. Študijski krožki spodbujajo sodelovanje, spodbujajo komunikacijske veščine, socialne veščine in tudi nekako delujejo povezovalno z samo lokalno skupnostjo. Starejši odrasli so seveda pogosto izpostavljeni osamljenosti, socialni izolaciji, posebej po upokojitvi se marsikdaj zmanjšajo socialne mreže. Zato je v bistvu vključevanje v neke izobraževalne dejavnosti zelo pozitivno, ker ohranja te socialne stike in hkrati tudi daje nek občutek pripadnosti. Skozi takšen način vključevanja pa starejši tudi razvijajo svoj socialni kapital, se pravi socialne mreže, sodelovanje med udeleženci z okoljem in tudi nekako razvijajo zaupanje do sebe in do okolja. In tako so v bistvu starejši odrasli postanejo aktivni soustvarjalci lokalne skupnosti. Mi smo pripravili študijski krožek pisane voščilnice za skupnost za člane Univerze za tretje življenjsko obdobje, ki je potekalo v knjižnici v Bistrici ob Sotli. Z temi člani sodelujemo redno in že par let za njih pripravljamo študijske krožke. Tokrat smo pripravili študijski krožek, kjer smo s člani ustvarjali voščilnice za starejše občane v lokalni skupnosti. Starejši so pravzaprav sami predlagali to temo. Šlo pa je pravzaprav za povezovanje na eni strani učenja, kjer smo kreativno ustvarjali, se pogovarjali, izdelovali voščilnice in na drugi strani tudi za neko medsebojno podporo, za druženje in tako naprej. Imeli smo 7 srečanj in ob tem smo naredili več kot 250 ročno izdelanih voščilnic. Te voščilnice so potem člani študijskega krožka v večini tudi osebno predali starejšim v njihovi lokalni skupnosti, se pravi starejšim, tisti, ki so nad 65 let. Udeleženci so ob tem seveda doživljali veliko, bom rekla, prijetnih občutkov, koristnosti, počutili so se zelo koristne, povezane drug z drugim in tudi z lokalnim okoljem, veliko so izražali tudi navdušenja, da so pač lahko nekomu bližnjemu v svojem lokalnem okolju tudi polepšali dan. V tej raziskavi, ki smo jo potem delali na podlagi tega študijskega krožka, smo pravzaprav želeli pa proučiti te socialne učinke sodelovanja starejših odraslih v študijskem krožku, se pravi v tej neformalni obliki izobraževanja. Tukaj so nas predvsem zanimali, kakšne so izkušnje odraslih, vpliv sodelovanja, kakšne socialne vezi so se oblikovale, ta občutek pripadnosti, in pa kakšna vloga študijskih krožkov pravzaprav je pri aktivnem staranju v lokalnem okolju. Tako smo si zastavili 2 raziskovalni vprašanji. Prvega, kako v bistvu starejši odrasli doživljajo samo to sodelovanje v študijskem krožku, in kot drugo vprašanje, kakšen vpliv pa ima to sodelovanje na to socialno mrežo, na socialne odnose in na ta občutek pripadnosti v lokalni skupnosti. Želeli smo raziskati, kako starejši odrasli doživljajo sodelovanje, kakšne socialne učinke imajo in tudi proučiti sam prispevek študijskih krožkov k socialni vključenosti, socialnemu kapitalu v lokalni skupnosti. Imeli smo študijo primera, se pravi ta naš krožek, ki smo ga organizirali. Potem smo nekako naredili poglobljeno razumevanje izkušenj udeležencev, se pravi, pridobivali smo te podatke na 2 načina, na eni strani z opazovanjem z udeležbo, na drugi strani pa z polstrukturiranimi intervjuji z udeleženci, ki smo jih naredili po zaključku našega krožka, in potem smo naredili tudi kvalitativno vsebinsko analizo podatkov, ki smo jih zbrali. Ta raziskava je bila izvedena v okviru tega študijskega krožka, pisana voščilnica za skupnost. V sam krožek je bilo vključenih 10 udeležencev, vsi so bili starejši odrasli, se pravi 65 let ali več. Vzorec pa je bil namenski, ker so se pač udeleženci prostovoljno odločili tako za vključitev v sam krožek, kakor tudi so se strinjali z samo raziskavo. Krožek je potekal od septembra 2025 in do decembra 2025. Srečanja pa so potekala 2-krat mesečno. To je bil sicer eden krožek, drugače pa v bistvu 2-krat na leto organiziramo takšne krožke za te udeležence. In potem smo pravzaprav gledali, kakšni so socialni učinki sodelovanja starejših v študijskem krožku. Rezultati so pokazali kot prvo zmanjšanje občutka osamljenosti in socialne izolacije. Tako so v bistvu udeleženci rekli, da imajo veliko več nekih rednih socialnih stikov, kjer se redno srečujejo z temi udeleženci, ko so vključeni v sam krožek, da imajo več nekega strukturiranega časa, ki je nekako koristno porabljen, da se ob tem počutijo boljše, da se jim je spremenilo razpoloženje, da manj razmišljajo o sami osamljenosti in tudi, da se manjkrat počutijo osamljene. Potem so tudi rekli, da čutijo neko večjo povezanost z drugimi udeleženci. In kot je napisala oziroma rekla ena udeleženka, krožek mi daje občutek, da imam reden stik z ljudmi in da nisem odveč. Potem smo ugotovili, da krožek predstavlja udeležencem nek pomemben prostor, kjer lahko vzpostavljajo in krepijo te socialne vezi. Stkala so se nova poznanstva, nekateri so se poznali že odprej, nekateri so se na novo spoznali in tudi spletli prijateljstva v okviru tega krožka. Dejali so, da jim je pomembna ta medsebojna podpora, ki jo čutijo v okviru krožka, in tudi zaupanje, ki ga doživljajo. Sam krožek pa jim predstavlja tudi eno pomembno socialno mrežo. In ena udeleženka je pač tudi rekla, da je v krožku spoznala ljudi, s katerimi se prej ni poznala in so postali tudi pravi prijatelji tekom izvajanja tega krožka. Udeleženci so krožek tudi velikokrat opisovali kot našo skupino, se pravi kot del nečesa skupnega in tako tudi izrazili to pripadnost skupini. Dejali so, da se počutijo zelo sprejete, da čutijo to pripadnost. Zelo jim je bilo všeč to netekmovalno okolje, podporno okolje, kjer so lahko dejansko to, kar so, kjer se počutijo tudi sproščene in so izrazili tudi neko zadovoljstvo ob samem vključevanju v ta krožek. In kot je ena udeleženka tudi rekla, počutim se sprejeto takšno, kot sem, in vem, da moje mnenje nekaj šteje. Potem so udeleženci tudi poudarili vidik koristnosti, da se počutijo s tem tudi koristne in aktivne. Se pravi, ko so izdelovali te voščilnice, na eni strani so se počutili koristne, ker delajo nekaj dobrega, ker so kreativni, ker so ustvarjalni, na drugi strani pa še ta koristni efekt, ko so v bistvu te voščilnice tudi nosili tem starejšim udeležencem in jim na ta način tudi polepšali dan, teden, mesec. Tako so v bistvu rekli, da se jim zdi pomembno, da pač so lahko ti aktivni udeleženci v skupnosti, kjer bivajo. Dejali so, da so potem to pridobljeno znanje, ki so ga dobili na krožku, lahko prenašali tudi na mlajšo generacijo, ker so te voščilnice tudi izdelovali kasneje doma s svojimi vnuki. Voščilnice so tudi izdelovali za svoje najbližje, za svoje sorodnike, prijatelje, in ob tem so izrazili tudi porast samozavesti. In ena udeleženka je tudi poudarila, da je pomembno in prav ta vidik, da lahko nekaj prispeva družbi in da niso starejši nevidni, kot jih pač v družbi velikokrat vidimo.
Čas bo potekel.
Aha, tole imam zadnjo, okej. Ta zadnji vidik je pa krožek kot prostor učenja in druženja, kjer gre za eno sproščeno, sodelovalno učno okolje in kjer se tudi zgodi vse večja motivacija. Tako da to, kar smo v bistvu želeli raziskati, smo v bistvu ugotovili, da so študijski krožki tisti pomemben vidik, ki pomaga pri zmanjševanju socialne izolacije starejših, kjer se spodbuja razvoj socialnih odnosov, občutek pripadnosti, starejšim omogoča aktivno sodelovanje v lokalni skupnosti in pa prispevajo k socialni vključenosti in aktivnemu staranju. Tako, hvala.
Hvala, Mihajla. With that title, z tem prispevkom zaključujemo naš panel in vas vabim k diskusiji in postavljanju vprašanj. Rekli smo, da bomo ta del izvedli v slovenščini, tako da vas vabim, če ima kdo za kogarkoli kakšno vprašanje, da ga sedaj zastavite. Vkolikor nimate vprašanj, zaključujem ta panel. Se vam zahvaljujem za vaše sodelovanje in vas vabim k nadaljevanju ob 16. uri, ko bo vaša moderatorka Alenka Križnik. Do takrat pa vam želim prijetno pauzo, malo počitka in uživajte v tistem kosu pice.
Če smem, prosim samo udeležence, če lahko izpolnijo anketo.
Izpolnite anketo. Najlepša hvala.